and delighted to speak to you all again. It's sort of a, I'm just really happy for the opportunity to do this. The work is so important. And Bob Wickline, I smiled when you mentioned about how music resonates and makes people remember things. When I was in med school, I wrote a song that has all of the enzymes of glycolysis in order. And I still remember all of glycolysis. If you Google my name and you put my name into YouTube, you'll find a recording of me singing all of glycolysis. So it's useful information for you someday. The run of show tonight is going to be basically in 3 parts. In about a minute or so, I'm going to slip into character as if I'm speaking to one of the more typical audiences that I talk to, perhaps a Rotary Club or some group where they're not as experienced on the topic, and I just lost my whole thing. Somebody shared their screen. Now I don't know what's going on.
I may have done it accidentally.
My computer says I'm viewing Jeannie Nicholson's screen.
Right. That's not what we want.
Yeah.
Are we back to my stuff?
Yep. Yep.
Okay. Oh, Zoom. Is there nothing you can't do? So the first part will be sort of a demo, as you sort of asked me to do, and we'll do that. And then we'll go into almost an autopsy, where I'll dissect the first part and try to show you how some of the things that may have been obvious, but that will, maybe some of them weren't obvious, how I try to apply the concepts from the last time we met into building this conversation tonight. So I'll try to show you how to do that. And then the third part will be, I think we'll have plenty of time for an open dialogue where we can have a discussion, question and answer. I know last time we convened, I learned several useful things from that part, so I'm looking forward to it. So with no further ado, I'll go ahead and start. So, hi, I'm Ed Weisbart. Thanks for inviting me. I chair the Missouri chapter of Physicians for a National Health Program. And I'll bet you're wondering why we're talking about healthcare at a time that the country is in such a crisis. And part of the reason that I think you're interested in it and why you're here tonight is because healthcare has been in crisis for a while, and the COVID-19 experience is making us even more aware of some of the problems. And part of why I wanted to talk to you tonight is because I think Medicare can serve as part of the rescue of how we can get out of the problems that we have, some of the problems that we have with the crisis at hand. So to get to that, first I want to tell you a bit about my family, my mother-in-law, and there she is, hi Ma. So if you don't think that's the most beautiful mother-in-law in the world, you can leave the room right now and you can log off. I have my mother-in-law's permission to tell you this story. So she lives in Florida. She has a rare cardiac condition, a rare genetic cardiac condition. And there's no one in Florida that has any experience treating it. But I live in St. Louis, and it happens that there are 3 places in the country that do have experience at that. And one of them is here in St. Louis. So we flew Ma from Florida to St. Louis, where she got arguably world-class care and went back home. And this was 7, I think, years ago. And it worked great. She has gotten no bills from that. She can come here without having to ask anybody for permission. Indeed, I managed her care and didn't have to call anybody for authorization of any sort because she has Medicare and a supplement. She can go anywhere she wants and didn't have to pay any out-of-pocket expense. She has one of those kind of supplements and did great with it. She, now 7 years later, has yet to receive any surprise bills, not the anesthesia, not anything, no surprises. And the key is that it's now, years later, she is now 90, and she trusts that Medicare has been there for, 25 years, and she trusts that it will always be there for her. And if she had to worry about that, if she saw somebody thinking about messing up their Medicare, that's what she would start to look like. She does not want her insurance to be threatened. But we know that it is being threatened for a lot of people. It's not just my mother-in-law. A lot of us have the experience of going to a physician's office, and we go to the window and we notice this little sign there, this placard, that we may or may not pay much attention to. It says something like this: "We're sorry, your doctor's office no longer accepts these insurances." And then there's a list, and you look at your card and you look at the list and you go, "Oh, thank goodness I'm not on that list." And then usually forget that the sign is there and you move on. So that's a very polite way of making the sign. A perhaps more honest way would be to say, it's not your fault, but this is goodbye. We found other patients whose insurance will pay us more. That's what that little sign really means. It's not your fault, but this is goodbye. We're gonna no longer accept you as a patient because we have other insurance products that will pay us more than yours does. And it's not just, you know, the one-offs, it's every place. You know, we kind of think that our insurance is reliable, that we can count on it. But what was the first thing that General Motors did when UAW went on strike a few months ago? The very first thing that their employer did, that General Motors did, was they took away their health insurance. And I don't know if you've had many conversations with union folks, but until that sort of thing started happening, most of them perceived their health care as a rock solid, reliable part of their life. And the strike taught us that even for a solid, hardworking, aggressive union like UAW, even their health care can disappear in the blink of an eye. So that's just not right. So what's so great about Medicare? Why are we talking about a system built on Medicare? There's three things I would say. The first is it's yours. And you're in control of it, as I sort of demonstrated over the past couple of minutes. Second thing is Medicare does not waste your money. And thirdly, it makes you live longer and healthier. So I want to unpack those last 2 points a little bit more. So first, Medicare means we don't have to waste our money. Here's the insurance overhead for the larger insurance companies. On the bottom of the chart there, you'll see a footnote. And that's going to be a footnote will be on all of my slides where there's numbers, as this one will. It's probably too small for you to read, but if you need the source, we can kind of put our noses up to it and read it. But just to show you that the data is public domain, sort of available, creditable sources. This data is, for example, from SEC. So the overhead for the insurance companies is, as you may have known, in the 12 to 18%, and some are actually considerably higher. The overhead for Medicare, on the other hand, is a remarkable 2.3%, and that's all in, including the brick and mortar and everything of the government offices that they operate out of. And it's not magic, right? The insurance companies have high overhead because they have to pay for the ads on TV. They have to hire all the people that say no to the stuff we want. They have to pay commissions and profits and sales and marketing and large salaries. And Medicare, frankly, doesn't have to do any of that. So Medicare operates with a remarkably small overhead. And these numbers, as dramatic as they may appear to you, are actually the smaller part of where we're wasting our money is. So we're wasting our money in terms of paying for large overhead for these insurance companies, but even more than this part of the number, they've managed to hide their overhead in medical offices and in hospitals. Doctors spend about $100,000 a year on staff who just manage the insurance companies. That has to come out of the rates. That's what's part of it determines the rates. And hospitals actually have enormous staff. We have about 900,000 hospital beds in the United States, and we have roughly 900,000 people working in hospitals in billing and insurance-related functions. So the average hospital could put somebody full-time at the foot of every bed from billing, not from nursing, but from billing. And here's Duke's data, actually. So some hospitals have more and some have fewer billing staff. Duke has 957 hospital beds across their system. And publicly reported, they employ a billing staff of 1,600 people. 1,600 billing staff to deal with 1,000 hospital beds. So there's a lot of money being spent in there. And understand, we're the only country that does this. You know, we're the only country that puts our healthcare dollars like this. Toronto General, with about 600 beds, I think it is, has 12 billing staff. So that's money that they're not spending and that they're able to spend on healthcare instead. What's the one reason we have the insurance companies that demand this overhead? It's because they claim that they can keep the cost of healthcare under control. So that's a good thing. We want them to do that, but how well do they perform? Well, here's data from the last 8 years about how much the insurance companies have spent per enrollee since 2008, the trend over time. And what turns out is that in the private insurance industry, the cost of healthcare has gone up by nearly 53% over the last 10 years. Is that a lot? Is that a little? Well, it turns out that Medicare has kept that down to less than half of that. So the one thing that we pay the insurance companies to do to control the cost of insurance and to keep us from having to waste money in healthcare, the one thing we want them to do, it turns out Medicare is phenomenally better at that than the insurance companies are. So that's interesting. But, you know, I'm a doctor, so the part that I'm more interested in, frankly, is the health of Americans. And here's some data from the Institute of Medicine that looks at our life expectancy compared to life expectancies elsewhere in the modern world. And you didn't need me to tell you this, I knew this before I came in. American life expectancies are actually 3 or 4 years shorter than elsewhere in the world. Our lives are being cut short compared to those elsewhere in the modern world. You knew that before we came in. This particular chart, which I promise you is my wonkiest chart, looks at that data by age. So on the left-hand side, you see babies, then you see kids, then you see younger adults, older adults, and on the right-hand side, you see 90-year-olds, 95-year-olds and such. And it's our ranking against the rest of the world, against 17 peer nations. And no surprise, given what you already knew and what I said a moment ago, we come in worst in the modern world. Our lives are being cut short, and we come in worst in the modern world until we turn 65. And then it's amazing, but country by country and year by year, we climb to best in the world. So we have much to be proud of. You can't become best in the world unless you happen to have many of the world's best. Doctors and hospitals and nurses and pharmacists and all that. We obviously do, or we couldn't possibly accomplish that. The problem, to me, is pretty obvious. We just don't let everybody in. We put a paywall in the way of healthcare. So what are we talking about tonight as a solution to this? We're talking about what's called single payer or Medicare for all. You've probably heard these words, but they basically mean two things. First, they say take Medicare and protect it, because you probably know Medicare is under attack, and that would make my mother-in-law very unhappy, and now me, since I have it too. So protect Medicare and make it better. There's some things about it that need to be made better. And then stop leaving people out. Nobody should be left out. So what does protecting it and making it better mean? First, get all the care that we each need. We each need these things. Everybody needs prescription drugs. Everybody needs eyeglasses, dentistry, hearing aids. There's about 15 or 20 of these things that we need that Medicare doesn't cover today and that people buy supplements and things for. We need that. So the first thing when we say Medicare for all is we really mean improving it, making it better. Put in the things that we all need, like prescription drugs and eyeglasses. And then fund it like we fund other public goods. Fund it like we do the fire department. We should no longer have co-pays or deductibles or premiums or have to pay for supplements or any of that stuff. You don't pay those things for the fire department, usually in most places. So fund it like we do other important public goods like the fire department, and just do it through a fair and equitable tax system. And leave nobody out, right? That means include you, include me, include all of my friends, all of your friends, all of our family, all of our neighbors, include everybody in the town next door, in the town down this, in the town across in the other states. Everybody, include everybody in this. And nobody should be left out, including really no doctors or hospitals. I guess in rare cases, maybe you'd find a doctor that would choose not to participate, but basically you personally would pick the best, whatever you think is the best doctor and hospital for you. You would be in control of that. You wouldn't have to check with a crazy network system. You personally choose the doctors and hospitals whom you think are best for you. And Congress should be in the same plan. There's no reason that Congress should have some different plan, or that the president or the mayor should have some different plan. Everybody should be in this plan. Nobody should be left out. Now you're probably asking yourself, gee, that sounds just, lovely, but how in the world can we afford this? You're probably asking yourself that. And I'm going to tell you that we're already paying more than we would need to. So here's us compared to all these other countries, and I could put more that would look the same pattern, and you can see that our public dollars, our tax-funded dollars, that pay for the military and Medicare and Medicaid, the tax write-offs we give to employers for paying for insurance, everybody, all the public dollars today comes up to almost the most money in the world per person. And we leave tens of millions of Americans uninsured and more very fragile. And then if you add in the private insurance, what we pay Blue Cross and Aetna and all of those, we come to more than $11,000 per person. almost double what any other country what almost any other country is paying. So we're paying plenty for this. If those other countries can afford to do it, we can afford to do something like this too. And it's not just my word. It turns out that there have been dozens of studies from economists all over the country that said that the savings that we would get from this would at least fund the expansion in coverage. Actually, 253 economists recently came out and said the time is now for Medicare for all. So of course we can afford to do this. What do we learn from COVID? Now, we learned a few important things. The first is that the American people really can rely on Medicare. And we need to, right? We each need our healthcare. If you're white, black, brown, any person who needs healthcare should be able to get healthcare. We've discovered this. It's so clear from people who get sick and are potentially infectious. We each need our healthcare, and we each need each other to have their healthcare. We each need our hospitals. We're actually, because of the pandemic, we're actually furloughing and sometimes firing physicians and nurses and closing some hospitals during a pandemic. In other countries that are pandemic stricken, much like we are, they're able to redeploy their nurses and doctors into the areas that really need them so that they're able to balance their resources. We have no capacity to do that. We just can't do that. And we need our hospitals, we need our nurses, we need all of these things. And then lastly, the lesson, of course, is that we're all in this together. Working together is simply the right thing to do. And it turns out that working together is also the smart thing to do. So if you want to hear more, you can go to our organization, Physicians for a National Health Program, at our website, Show Me Medicare for All here in Missouri. Show Me Medicare for All. So that's the talk, basically. I sort of excluded a whole bunch of parts of it because I wanted to make it fit in the demonstration sort of mode. Now, if you don't mind, why don't we go straight into sort of the autopsy? This is a certain autopsy suite that I think has been affected by COVID because there's no one in it. So it's being very socially distanced. So first thing, I called this talk Healthcare in Crisis, Medicare to the Rescue. So why do I like to call it that? A crisis is a bad thing. Nobody likes a crisis, well, very few people like a crisis, and rescuing is good. So I'm trying to set up that we have a crisis and trying to associate Medicare to the rescue as a good thing. And the key arguments, I think, for us for the next period of time are that employer-based insurance is inherently unstable and that Medicare can actually be cast as the hero of this story. I don't know if you're fans of Rachel Maddow, but I'm a Rachel Maddow junkie, and I've noticed one thing about her that used to drive me crazy, but that I have learned to really appreciate. When she tells a story, as a point she wants to make, she often starts off the story from 3 different ways. She'll tell the story once, and then she'll completely change her attack in and tell it a second time, and then completely change her attack in and tell it a third time. And that used to drive me crazy because I wanted to hit the fast forward button. But I have a number of friends who have not been focused on very much on politics until they discovered her. And for the first time, they were able to understand politics. So a lesson I learned from her is that it's good sometimes to make the exact same point in different ways. And that's what we did, right? The first iteration of healthcare needs to be stable was my mother-in-law's story, right? And I hope showing a picture of her activated your nurturing frame, as we talked about last time. And then we also talked about this story, which is the second way of saying healthcare needs to be stable. And you probably were paying attention, I'll bet you noticed, because I kind of beat it over the head, that it's not your fault. This could happen to anybody. Remember, that was one of the lessons that we talked about. And then UAW, the strike, was sort of a third example of healthcare not being as secure as maybe it once seemed. So this section of the talk was intending to set up the concept that we don't have a stable and secure system. And I brought up 3 points about what's so great about Medicare, and I hid in there the use of second person pronouns. Yours, you're in control, your money, you live longer. And this is a lesson that I learned from, of all people, Rush Limbaugh. It turns out your choice of pronouns is really important. First person pronouns take ownership, first person singular. You know, I'm gonna do this, I'm gonna do that, I did this. I don't know how many salespeople I fell for before I recognized pronouns. First person singular is the most powerful. First person plural, not quite as strong. Second person pronouns, you, are very engaging. If you're listening to somebody and they say, well, you know this, you're thinking, yeah, I do know that. You know, maybe you're not, you know, publicly uninhibited enough to say that, but if you're driving in your car and somebody says, well, you know, and Rush Limbaugh does that a lot, it's more engaging. So I try to use second person pronouns in that part. I should have gotten a glass of water, sorry. And then in this chart, there's two things I wanted to point out. The first is sort of a covert use of colors. When I'm showing something that is bad, I often try to show it in red because red's a scarier color. When I'm showing something that's good, I try to show it in green. Red is bigger and green seems smaller. So most of my charts I try to design like that. But the more important point was I called this stop wasting our money. So stop wasting. Turns out there's this behavioral economics principle that I think I talked about loss aversion, and stop wasting is much more potent than start saving. So save your money, nowhere near as effective as stop wasting your money. And then our money, trying to bring it together. So I used the stop wasting concept 3 times. Stop wasting our money on bureaucracy. So you saw stop wasting coming up a few times. And then this chart is, I think, a really important chart, and it's really important how you handle this chart. So this is an example of showing really dreadful information, right? That we have the worst life expectancies in the modern world. We rank terribly on the left-hand side. And so if you're talking to somebody for whom loyalty is an important, gosh, I got water. For whom loyalty is a critical core value, that set of data saying that our life expectancies are short, any of that stuff is threatening. And the best way to say it, to be the most threatening, is to say years of life are being taken away from us. Again, loss aversion. But you can't stop there. If you show something dreadfully wrong with the United States, you've got to give them a way out. And on this chart, you got to give them a way to redeem their sense of loyalty. So on this chart, the stuff on the left-hand side is a direct threat to loyalty, and conservatives will start to want to shut down when they hear you talking too much about it. And that's why I quickly followed up with the right-hand side of the chart, which I think validates our reason for loyalty. And that's why I made a point to call out that we have to have many of the country's best doctors, hospitals, nurses. It wasn't just an empty compliment. It was intended to put them back at ease with a sense of loyalty towards the country. So it was a fairly well thought out, fairly carefully constructed discussion on that portion of it. And then I try to structure the description of Medicare for All in ways that make the most use of the concepts. So to start off, protecting. Talking about protecting Medicare is, again, protecting anything activates nurturing, again, hitting a Lakoff frame. All the care we each need, again, trying to hit into tribalism, we each need all this care. So trying to hit tribalism without hitting others. We all need this, we each need this. And then funded like the fire department. Most people kind of like the fire department. There's an awful lot of other public services that are more controversial, but the fire department, I don't know anybody that doesn't like the fire department. So it's a pretty easily accepted part of the common good, you know, so why not fund it like as we do the fire department? And then on the other collection of things, nobody left out includes you and me. Nobody left out. Again, tribalism without tapping others. You personally choose. This is an attempt to appeal to libertarians. You choose. Personal liberty, you feel, it's that portion of it. In Congress, I don't know what concept this is, but I'm here to tell you, whenever I give this talk, when I point out that Congress would be included and that the president would be included under the same plan, half of the crowd claps. It really resonates to hear that Congress is included in this. So that's an important point to make. And then here, you're asking, how can we afford this? Notice how I phrased that. You're asking yourself, how can we afford this? It's my attempt to channel Rush Limbaugh. And you're welcome. I spent 6 months listening to him for 5 minutes twice a week to try to pick up on his skill set. That's all I can handle, and I haven't been able to do it again. But he does things like this all the time. You're asking yourself. So If they can afford it, we can too. This is an attempt to get to prudence and to loyalty. And then this is an important way to look at it, I think. If you notice, this doesn't have the granularity that we're used to using. First of all, this taps into authority. So I made this list of economists, and you choose your audience. Some audiences hate authorities. But in conservative audiences, having authorities is usually something that's respected. So use it judiciously. And notice too that I didn't do what maybe some of you have seen me do in the past. I used to walk through the detail of something like Elizabeth Warren's tax plan or the Perry Institutes, or the Perry analysis. I used to walk through all of the economics thinking I'm going to prove that this isn't scary, not realizing that just talking about the details, even though I thought the details were reassuring, just talking about the details made them more ominous. So this goes back to the I have a dream rather than I have a plan. This is an attempt to avoid the details. Keep them in your pocket, you need them for answers, have them, but probably not good to dwell so much on the plan, more on the vision and the dream. Lengthy plans are easily characterized as just big government. And then the lessons, I'm not going to walk through them in complete detail, but the American people can rely. So again, the American people, this is an attempt to tap loyalty and tribalism, and be proud of that word, own that word. And the American people, because people have faces and are less like others and can rely on, not Medicare is provided to, or the American people are entitled to, but we can rely, even though those are all true in my mind, but rely upon, I think, is a better way to put it. Not users, not takers. The last thing I wanted to call out was this wonky slide with all of this information. The reason I want to call this out for you is because of the name, the website we came up with, showmemedicareforall.org. I used to tell people go to pnhpmo.org, which was really easy for me to remember because it was Physicians for a National Health Program, Missouri. But whenever I'd be on the radio and the interviewer would ask me, so where can they go for more information? And I'd say, oh, go to pnhpmo.org. And the interviewer would say, PNH, what was that? And I realized, or they aggressively told me, that that's a terrible name. So we made up a fake landing page, showmemedicareforall.org. You guys, the One Payer States group is, as an organization, is already ahead of that curve, but I wonder if each of your chapters are. So we made a fake landing page, Show Me Medicare for All. You click anywhere on that page and you go to the more detailed page that we already built. So be thoughtful about what you make as your landing page. At a minimum, have it as a landing page, if not more than that. So let me stop sharing, and we have plenty of time for chit chat.
Thank you.
How do you want to do this, Mike?
So Betty, you want to lead the discussion? You're still muted. Here you go.
Well, let's see. Do people know how to raise their hands on the participants bar? If you scroll down, if you scroll your cursor down to the participants bar, we talked about this a little bit before the presentation to find where the chat bar was. So if you see the participants bar, it shows 40 people. Then if you click on that, then you see a place where you can raise your hand. And I see Shelley Rice has her hand raised. Shelley, can you unmute yourself and ask a question, please?
Oh, I was just showing that I knew how to raise my hand. Sorry.
Okay, no worries, no worries. And Alex, did you have a question or were you also just demonstrating? Alex Polikoff?
No, I have a question. I actually have several, but I'll just ask one and then get in the back of the queue. So, well, maybe I'll ask two.
Go for it.
First off, great presentation. I really like the way you framed that. So thanks so much. A couple questions. First off, you had one slide that did show single payer up there, and I'm with Mid Valley Healthcare in Corvallis, and we're always in the throes of how to the best way to message. Healthcare or single payer versus publicly funded versus just universal health care. So, and you never really defined single payer, you just said single payer Medicare up there. So so my question would be, have you found in your presentations where people still ask you what single payer is? And is that kind of a little bit confusing just to throw it up there without really defining it at all?
So, that's a really, I think, important question. On a broader scale, what that makes me be thinking about is when I started doing these talks, I would get a question at the end of it. And then the next time I would give the talk, I would make a point to proactively embed the answer to that question in the talk, thinking that, well, that I don't have to be asked that question, and there's probably more people wondering. So I wound up with a really long presentation that was answering questions that some of the people had, but not all the people. And what, frankly, my wife taught me when she gave me critiques on this was that it's better to have your talk be as Spartan as you can make it, as little in the organized comments as you can, have answers to all that stuff in your pocket for a couple of reasons. One, it requires less attention span, but number two, it makes the audience feel ownership and engagement over the discussion. So I used to spend quite a bit of time defining these terms, and I usually don't anymore, especially nowadays that it's above the fold and people are thinking about the topic. And if they haven't realized they don't understand what those words mean, we can certainly explain it. If they do realize it, we want to know. So I say that as a secondary question. Which term is best to use? Single payer, Medicare for all, universal health care, a national improved Medicare for all? I don't know. I know there's been survey data that shows that some of those phrases are more resonant than others. Socialized medicine actually scores more favorably than I had expected it would. So some data shows that's more favorably received than others. Here in Missouri, I am not about to start saying socialized medicine is so you want to, or actually here in Missouri, I would say. So you want to be thoughtful about your audience and which way you want to define it. And I would say it's probably less important which one you pick than it is that you focus on the content rather than the title. It's my guess. I'll bet there's people here that have better answers than that, though.
Thank you. I do think that's actually still a very poorly understood question. People don't know which one works best. And it is so audience dependent, geographic dependent, even local audience, depending on who's been using what language, very local. I see Warren George has his hand up. Do you still have a question, Warren? Can you unmute yourself, please?
Yeah, it's half comment and half question. You painted a pretty rosy picture of Medicare that made a few of us chuckle. My own experience is having lost my physician at the age of about 60. I went for a number of years. I could not find a physician who would take me because of my age. And they don't want to drop you once you've turned 65 and are on Medicare, but they can drop you beforehand. So there is certainly downsides of Medicare. But on the upside is I noticed on the poll that we did in Oregon, and this is actually another comment that you can comment on, the people who were satisfied with their health care, 69% of those over age 65 in Oregon, 42% of those under age 65. So, Medicare may have its problems. It's way more popular in Oregon than private care. But you're free to comment on my comments.
Sure. Well, I'm sorry you had the trouble getting insurance coverage and getting a doctor. That's a nightmare when it happens. So I'm sorry to hear about that. I think you're right that not every person in every audience has a completely positive view of Medicare. So it's not unusual for me to have physicians complain about it, or you have patients complain about it and say, you know, I couldn't get this or that or the other thing. And what I've found is that I'll bet 90% of the time when somebody tells me that they didn't like Medicare, that they don't like Medicare, I'll bet 90% of the time when I hear that, it's somebody who has Medicare Advantage. And they don't understand the difference between traditional Medicare and Medicare Advantage. And for that reason, I used to kind of do a deep dive into what those differences are. But I have moved that for non-senior audiences, I've moved that to the back pocket kind of topic. If I have an audience that's like 63 to 67 years old, I make a point to focus on it because they've actually got a decision to make there. But for everybody else, I don't have that discussion. Then there's the people for whom Medicare, you know, is flawed, you know, didn't cover yada yada or whatever. Those are unusual and usually can be addressed with the concept of that's one of the things we need to improve about it.
Thank you, Ed. Barbara Pearson, you had a question? Can you unmute yourself?
Yes, well, I was just going to suggest there was a strong conversation in the chat of a psychiatrist in our audience who at point after point after point was kind of refuting your points about Medicare, that for psychiatry, apparently Medicare is particularly punitive, and I don't know how it compares to private paying insurance companies, whether there is as well as better funding than the Medicare. But I wondered if you had somebody like that, and if somebody could read it, or I can try and find them and read some of the comments, what kind of things you say to that.
So in terms of mental health, the two things that I would say about psychiatry are, number one, both of the bills, Medicare for All under both bills, has mental health parity. So that under both bills, your ability to get mental health is treated just like your ability to get any other part of healthcare. Right. So the people who crafted these bills recognize that there isn't this distinction. And so the bills will greatly elevate the respect the country demonstrates to mental health services. And that's really important in a lot of areas like where I live, where there's the opioid crisis, the opioid epidemics, and there's no place to get treatment and there's no coverage for that. So having mental health parity is good for psychiatrists and it's good for all of us. And then the second piece is that psychiatrists are notoriously underpaid in all sorts of areas. So we know that the way the fee schedules are established today are driven by the most lucratively reimbursed specialists, you know, by the MedPAC process, which is a whole discussion sort of beyond tonight's agenda. But the bills that we're talking about create a fee schedule, create a process for developing a fee structure that's much more aligned with the needs of public health. And of course, mental health is very high on that list. So we should be able to address both of the concerns that person was raising.
Thank you, Ed. Thank you. David Young, you had a question?
Yeah, regarding the expression universal health care, I tend to downplay the use of that one. And if somebody asks me about it, I point out that the insurance companies want universal health care. All you have to do is pay the premiums and we'll all have universal health care.
Yeah, I agree with that. And also, you know, last time when we were talking, I brought up the idea that universal sort of triggers racism and other things and undermines tribalism. So I don't think I ever used the phrase universal healthcare. But again, it depends who you're asking, who you're talking to. I don't use that phrase very much at all. And you're exactly right. But none of these phrases are that specific. You know, single payer could also be Blue Cross for the entire country, right? You know.
So when you say you don't use universal at all, you mean not with any audiences? You just don't use it? I
don't think I ever use that phrase. I like the phrase "nobody left out." That seems to make the same point without triggering anything.
Thank you. And William Brunston, you have a question?
Beautiful, Ed. That was really great. Ed, how do you deal with neutralizing the folks that talk about a pathway or a roadmap that essentially are corrupted and really are happy with the status quo and really don't care if we ever get single payer.
So I think the best answer, or my answer to that anyway, is that if you look at either bill, so this was different when we had HR 676, right? HR 676 said, pass the bill, nothing changes, and 2 years later, we go from 0 to 100 miles an hour. And that used to scare the pants off of me. And back when we were under 676 as our goal, I said publicly everywhere I went, this is a flaw. I'm terrified by that because no matter how smart, clever, creative we are with this, there are going to be unintended consequences that we're going to screw something up. And going from 0 to 100 overnight, that's really risky. So I'm actually quite happy about the fact that the current bills have a 2 to 4 year transition. So when somebody says we need to do this more gradually, I say to them, well, I actually agree with that completely. I agree. But my concern is that you have to legislate that gradual change as a package. You have, if you just spend 5 years fighting to get the public option, you know, if we focus on the public option, we're going to spend 4 or 5 years fighting to get the public option, and then it'll take 2 or 3 years to make it go live. And then it'll take 2 or 3 years to assess it. It's going to be 10 years from now before we're ready to take the next step, best case scenario. So if we make the goal the public option just because we don't want to take too big of a step, that terrifies me. On the other hand, there's nothing wrong in my mind with creating a public option on day one and having it disappear at the end of the 2 or 4 year process. And that is what both bills do. So if somebody says they want to do an incremental approach, I say more power to you, and I agree, but let's legislate the end as we legislate the beginning of the increments. And let's not just take a half cup here.
But the option of getting Medicare for all includes an expanded Medicare that includes dentistry and all the other, you know, services. So it
Yeah.
really is not quite what people that are saying public option mean. They don't really talk about a changed Medicare. They talk about status quo.
Yeah. But then that comes down to how much granularity do you want to give to the person who's asking the question, because that, you know, you want to sort of pace that.
The
Right.
danger, there's tons of our friends that don't want this to happen that use our language.
Yep. Medicare for all who want it.
Right. Many ways of saying the same thing. Thank you very much. Thank you. Now I wanted to get to Henry Elder had a question. Are you muted, Henry?
Yes, I'm the psychiatrist that made the comments. I'm committed to single payer and you know, Medicare for all, but I have very great concerns about the inequality of the current way of dealing with things. There is a national attempt for parity for mental health, for example, but it doesn't get enforced. So I'm concerned about the contents of a single payer, and concerned about praising Medicare too much when there's so much clearly wrong with it. And so yeah, that's nice to say new and improved Medicare for all, but we've got to understand that places like Canada have trouble with, you know, adequately funding their fire department, their health care, and they fight with that all the time. We need to be careful about what we're proposing here. We need to not only provide health care, but adequately fund it.
So I agree exactly with what you're saying. Actually, I don't know if you know the history of this, but when the language was first being sort of bantered around, David Himmelstein of PNHP was pretty aggressively against as a movement, going towards the phrase Medicare for all, for the reasons you're saying. And he said that's, you know, we don't need to build it on Medicare. We're talking about so fundamentally transforming Medicare that's a very inaccurate and almost derailing language. And he was very aggressive towards saying we should be calling it just single payer. He lost that argument, and he publicly says, "Hey, I lost that fight. You know, we're calling it Medicare for all." You know, I can't, so, you know, I would say that at this point, that's the language that the country has settled on. But I couldn't agree with you more about it. The other thing I would say about what you just said is that this fight never ends. right? This fight never ends. One of my favorite stories is from Carol Paris, the past president of PNHP. And she, I don't know if you know this story, she doesn't tell it very often, so you probably don't. She's a psychiatrist, and one of her first forays into legislation was that she discovered in her town or area that all the patients from one of the insurance companies were coming to her, or a tremendous number. And so she called other psychiatrists in the community and said, hey, are you seeing all these people? And they said, no, we're not seeing them. And she looked at the insurance company's directory, and they had like 25 other psychiatrists within a few miles of her, all listed as in network. None of them were seeing any of them. And so she realized that the directory was nonsense. So Carol went to the state Department of Insurance and got a law passed requiring that those online directories and printed directories from the insurance companies be accurate, be up to date, and be correct. You know, she got that law passed, and she went home and she went, hooray, victory. What she didn't know, and what, you know, gets to your point, is that that's when the game starts. We, as naive advocates and activists, go home when we get the law. That's not the end of the game. That's the beginning of the game. It's the regulatory process. So she wasn't there at the regulatory committee meetings where they passed the language about what the penalty would be for violating the law on an inaccurate directory. And the penalty for an inaccurate directory was set at 0. So the point is exactly, your point is exactly right. That just because we may have mental health parity built into Medicare for all, that is not the end of the game. Funding is critical, all these other things become critical, and that's just the first thing we have to do, but then we don't go home.
Right, I think on mental health in particular, you know, I've spoken to people in the UK and all, and they're a vulnerable population. They can't advocate well for themselves with confidentiality and all. It's hard for other people to advocate for them. So they're the easy person for the insurance companies to not take care of. And even when you have a single payer system, again, they don't advocate well for themselves and due to confidence. So you still have the same issue. You still need to have other processes for making sure that the care is up to what you're looking for, what you need for everyone. Thank you. Now, Barbara Lamorticella, name right?
Yes. I wanted to ask Ed a question. When he talks about 2 bills, and I realize I came in on this late, is he talking about a Senate bill and a House bill? What
Yes.
are the 2 bills?
Yeah, and I'll bet some of you know the number better than I do, but there's a bill in the House sponsored by Pramila Jayapal. It has, I think, like 115 co-sponsors, and it's called the Medicare for All Act of 2019. And then there's a bill in the Senate sponsored by Bernie Sanders with about a dozen co-sponsors, and it's called the Medicare for All Act of 2019. And there are a few really important differences between the two, but the similarities are phenomenal. Matter of fact, most of the language of both bills is like cut and paste. I mean, it's often the same paragraph number, the same exact words, cut and paste. So for me, I used to go into the detail of the differences, but I think that's a little bit wonkier. You know, that's a next level discussion. And I just talk about it as the 2 bills. And I'm glad you brought this up because it's important to make the point, and I didn't do it tonight, but it's important to make the point that there are 2 bills, that there's a bill in the House and a bill in the Senate. Because if you remember from last month when I was talking, and I talked about the quadrants of the brain, some people, if they know there's a mechanism, they need to know a process. If they know there's a law that could be passed, if they know that changes it from a theoretical idea of some, you know, nice, well-meaning people into a real practical, oh, if we passed that bill, we would get this. So it's important to do a little more detail than I did tonight on the fact that there are 2 bills in the House, you know, in Congress.
Thank you.
Thank you. That's a good point. Okay, Alex Polikoff. Alex, are you?
Yeah, well, since I asked one before, maybe have the people go that haven't had a chance to ask a
Right,
question,
you're right.
and then I'll tag on after that.
Thank you so much for that consideration. Lynn Heidekoper.
Hi, how is everybody? I've been working on this for the last, I don't know, almost 25 years. Out of Healthcare for All California, we had several bills the legislature, and then Arnie Schwarzenegger vetoed both of them. Otherwise, we'd have single payer in California and the rest of the country. So I've been working at it for a while. Just on the Pramila Jayapal's bill is HR 1384. And I don't have Bernie's on my brain. It's S something. I think it's 4 digits.
1129.
There, yeah. I was going to say 29. Yeah, 1129. A couple of things. When I speak about a single payer, I qualify it's universal health care with single payer financing. That's how I usually do it, because you're absolutely right. Universal health care does not mean single payer. Now, I know that the reimbursement to physicians for Medicare is awful, as it is for Medicaid. It's ridiculous. And that's why a lot of doctors have dropped Medicare patients, because they get very little back. However, as a single payer plan for the patient, I've had several operations at Stanford in the last year, hundreds of ER visits, procedures, home care, rehab, etc. I figure my bill is easily about $400,000 or more, because Stanford is one of the most expensive hospitals in America. I have traditional Medicare and AARP. I have not paid 1 penny. I was hospitalized for depression a couple of years ago for a week, and then I got therapy for 2 years. I never got a bill. So that's why I love Medicare, and that's why I tell people, I give my story about how fabulous it is, because and I have AARP Plan F, which they're getting rid of. Another company, I tried to see, I was getting Medicare Part D with Humana, and I tried to see about health coverage, and they rejected me because I'm a high utilizer of healthcare. I have quite a few different problems. But anyway, so I love.
Barbara, did you have a question? We have a few more people who have questions too. Did you have a question for Ed?
Oh, I had one other thing. No, on salaries. The American Medical Association controls salaries of physicians in America. And that's why primary care physicians are also poorly reimbursed. And that's why medical students, when they tend to have to go to specialties to get higher salary to pay off their huge debt. So that system has to stop.
You know, I think your point about telling a personal story, you know, first of all, I'm really sorry to have heard your story, but I'm glad you were able to pull through it.
Yeah, no, I'm fine.
But I think those stories are compelling, and I think one of the other ways to approach that is something I learned from Claudia Fagan, the national coordinator of PNHP. She'll sometimes go to a meeting and she'll say, "Okay, we all know there's problems with health insurance. So raise your hand if you have health insurance." And most crowds, people all raise their hand. It's just, okay, we know it's screwed up, but keep your hand up if you think it's pretty good. And most people keep their hands up, they say more or less. So, okay, keep your hand up if it covers physical therapy. And they mostly keep your hand up if it covers physical therapy after a stroke. And some hands go down. Okay, they don't know. Keep your hand up if it covers 20 visits or more, and most of the hands. Keep your hand up if it covers physical, more than 20 visits for PT in your house, or if you have to go to the house, and all the hands go down. And she says, that's the point. You just told me you think you have good health insurance, and you have no idea what your insurance covers or how well it works. And that seems to get through to a few people. Well, thank you. Betty?
That's a good example. Wow, thank you. I'm going to go, Chuck Pinocchio hasn't asked a question yet. Could you unmute yourself?
Do you hear me, Betty?
Yep.
You do? Okay, good. I'll pop my video back up here. Ed, thanks so much. Your thoughts are always enlightening and really elevate the discussion. I especially appreciate your focus on values and vision and story. I think that's what really elevates the discussion for most people. Most folks out there are not policy wonks, as you know. So thank you for that. Now, I just want to say, just as a statement of respect for all the folks who work with PNHP, and we love PNHP, and we focus on national bills. Our primary focus is on state bills. And I did also put in the chat here the Healthcare Emergency Guarantee Act bills, which are important at this moment during the pandemic. Jayapal and Sanders have pandemic bills as well that need attention. So people could take a look at that in the chat. But just to say that there are a number of states, California, Oregon, Washington, Minnesota, Maine, and New York, just to name a few, that are making real serious progress here. And especially as governors are meeting with each other and talking about how do we recover economically as a region. I just want to see if you have any thoughts on possible pathways politically from the states or even the regions, given the history of the United States, which is where most reforms do in fact start at the state level. And we do have a federal system similar to Canada. And of course, Canada got started in Saskatchewan. So we just like to keep our eye on every ball and every opportunity possible. Our mission statement talks about working at the state, regional, and national level. I'd just love to hear some of your thoughts on that, Ed. Thank you.
So I think you probably know a lot more about this piece of it than I do. I would say broadly, I think I agree completely with your idea that we should work at every pathway we could think of and keep moving forward on them all. I live in Missouri, and there's no way in hell Missouri is going to pass anything resembling what you're talking about. So it's frankly not a piece that I've spent enough time focusing on. But I applaud. You know, you could make the argument that, of course, we could follow the Canada model and have a state go first, which then would have the trickle cascade into other states. And I think that's, it could be. But I'm quite sure that you know more about the content of that than I do. So I'll shut up about it.
Thank you, and I can appreciate that that may not be worth your time sorting through too much in Missouri, and you do provide a great service to so many of us in so many other areas. So Alex, you had a question, and you still have that question?
Oh yes, thank you. So one thing that interested me was you said the speech was going to be about how to talk directly to conservative audiences. So I'm going to bring up something that always comes up with conservative audiences that you didn't really directly address, but it was kind of in there. And, so at Mid-Valley, we have these shirts that say healthcare is a human right. Well, I've talked to enough conservatives that that's the big thing with them is healthcare is not a human right, right? So they don't think that's a human value. So pushing that doesn't go anywhere. So, I mean, their big thing is, why should I fund people, who are, on drugs or homeless or whatever, it's like a thing. I don't want to pay for other people's health care that don't want to contribute and aren't contributing, to society in some way. So I'm just wondering, I mean, how do you directly address that? I mean, I know I like the idea of like funding it like the fire department. I like that image, that's a great image. And it leads into this whole idea of the commons, but I want to ask you directly. I mean, I'm in a very conservative district, and there's a lot of people that are like that, including my current representative in the state house. And how do you talk specifically to people like that have do not feel any shared feeling towards people who aren't contributing monetarily like they would be?
So I'd say a few things. The first is, don't be as stupid as I was. When I started giving these talks, I used to open my talk with, we all agree that healthcare is a human right, right? So let's move on and figure out that's like, no, we don't all agree that healthcare is a human right. And what I quickly discovered was that if I opened up that can of worms, that would consume at least 10, if not 15 minutes of the circumscribed time window that I have. It's not like you have an open-ended 3 weeks discussion if you have time for it. You've got a start time and a stop time, and you get to decide somewhat how you allocate that time. And so for crying out loud, if we open the topic of healthcare as a human right, you can expect to spend 10, 15 minutes in a really interesting discussion about ethics and morality. And it's really interesting, but I would submit it's adjacent and not core to the question at hand. We don't have to answer the question of whether or not healthcare is a human right. If your goal is to reach into the liberal base and you want to bring them out, then the phrase healthcare is a human right is tapping core liberal values of nurturing and caring, and it resonates, and raising the banner healthcare is a human right might help get liberals out to vote, might help get liberals to support you, might swing some of the independents towards you. But oh my gosh, you know, it's much more likely to just drive conservatives insane. You know, and they'll say things like, "Where's that in the Bible? Where's that in the Constitution? A life, liberty, and the pursuit." Well, that's not really the same. You know, it's well, the World Health Organization says it's a human right. Well, who the hell's the World Health Organization? They're not in Missouri. You know, I mean, it's you're creating a whole cascade of things that you don't want. So the first part of my answer to you is, don't start that discussion. You have answers available if somebody else starts the discussion. Focus on the core that you want to talk about. But if it comes up, then when if somebody asks me, so do you think healthcare is a human right? Okay, here I lie, because I do. But I'd never answer that outside of friends. And what I would say, which is also true, is I don't know. I'm not an ethicist. I can't tell you what's a human right and what isn't. Actually, I can, but I can't tell you that. What I can tell you is that it's to my advantage to have you have healthcare. It's the same thing as if my neighbor can choose not to have the sewers drain his house or have the garbage picked up from his house. If he doesn't have the sewers drained from his house, well, guess what? Our neighbor is going to start to smell and my property value is going to go down. So does he have a human right to have sewer drainage? I don't know, but I can tell you it's what we call a common good. It's to all of our advantage that we all have this thing. If I want to go to a restaurant and I don't know, and I don't know if the person in front of me, if they have two lines at the restaurant, one says your servers at this line have health insurance and your servers in this line don't, so you can pay a little bit less for your meal because your servers here don't have health insurance. I'm going to go to the line where they have health insurance. You know, it's a common good, is how I would answer. And then the other piece with a conservative who says, I don't want to put my money on it when they're not putting their money on it is, so are you saying that if somebody comes to the ER with a heart attack and they don't have insurance and they don't have a gold card in their pocket and they don't have a bundle of cash, that I should not treat them and I should let them die? Now there's 1 or 2% of Americans that would say, well, yeah. 98% of Americans, I don't have stats, I'm making that up, but the overwhelming majority would say, no, treat them and we'll figure it out. Okay, if you want me to treat them for $50,000, I'd rather treat him for $10 a month to give him his blood pressure meds. If we're going to pick up the most expensive part because we can't stand the idea of letting him die, I want to prevent that. It's just a waste of money to do it the way you're approaching. And I'm too, maybe you're okay with wasting money like that. I am not. I am prudent. So if you're not prudent, okay. That's kind of how I maybe a little more aggressively than I usually would do it. Does that help?
Bob Wickline is waving his hand, but I see Barbara and Jean Nicholson have their hands up first.
Let them go. Please let them go.
So it looks like Jean Nicholson.
Please let them go.
Okay, Jean.
Dr. Weisbart.
You're on, Jeannie.
Dr. Weisbart. Can you hear me?
Yes.
Yeah.
Okay. There's a delay because I live in the mountains where there are no cell phone towers and we have to bounce things off of satellites. So forgive me for the lack of technology in exchange for living someplace beautiful in mountains. Dr. Weisbart, I am a former public health nurse and a former state senator. And I've been interested in healthcare for obvious reasons because of my background for many years, and particularly interested in how to communicate using shared values when I'm communicating, especially with conservative audiences. For example, the Rotarian organization in my local community would be considered a conservative audience. Your presentation, I think, is outstanding. Thank you so much for the work that you've done and how thoughtful you've been about employing the conservative values of tribalism, patriotism, loyalty, personal responsibility, hardworking Americans, all of those things I think resonate not only with conservative audiences, but also with liberal audiences. And so I think this presentation has tremendous value. I have a couple of, one comment and a couple of questions. One is, how would you incorporate the value of sanctity, which is also a shared common value between progressives and conservatives? And another question would be, could we consider talking about the American plan instead of Medicare? Because it sounds patriotic, and it also sounds new, implying incorporating some of the benefits of Medicare coverage and administrative savings, but might be more persuasive with certain audiences. It was a term that George Lakoff suggested that resonated with me as something that might bring in some of the conservative audiences. And then my last question, sorry, you know, politicians, we always have to talk. My last question is, which audiences have you presented your PowerPoint to, and how did they respond differently depending on the audience?
So thank you for all that. First, I don't know if you can see this. It's my Rotarian paperweight. I've done a lot of Rotary clubs. It's on my desk. I didn't have to look for it. I've done a lot of Rotary clubs. I confess I didn't know what they were not that many years ago, and I've learned tremendous respect for Rotary clubs. They actually do what they say they want to do in many cases. So I love them. The sanctity question, to me, that's one of the places where that chart that I showed you of American lives being cut short, where we were at the bottom for the first 65 years, and then we go to the top. I gave you sort of the shortened version of how I talk to it, but oftentimes I will point out that this means that our lives are shorter than they should be. We're having life taken away from us, basically. So there's a lot of places where you want to put that and put it in as a loss aversion rather than we can live longer. No, well, yeah, but make it a loss aversion. We're having years of our life taken away from us, you know, so that's sort of how I approach the sanctity piece. In terms of the word of an American health plan, I read that when Lakoff said that, and it resonated with me, but the idea of trying to change the language when we have language that seems to be, have a lot of traction, I'm not eager to do that. So the way I incorporated that comment of his was, for some audiences, for Rotary clubs actually, I'll often say something like, you know, I'll call the title of the talk Medicare for All or something like that. And then I'll say simple, prudent, and proudly American. So my catchphrase under my talk is simple, prudent, and proudly American. Because I think the word simple is something we need to repeat a lot of times. Because that's one of the things about our plan is you don't have to worry about all this stuff. It's simple, no plan G, no supplement, no this, simple. Prudent, you know, who doesn't like prudent? And proudly American, you know, we invented it, not really, but, you know, proudly American. So I agree with you. Those are important values to hit.
Thank you, Ed. I see that actually in the chat bar, Hank Abrams also had a question. Hank, are you in? Could you?
Sorry.
Yep, okay.
Sorry, I had to unmute. So I think this is a wonderful discussion, and I think there are a couple of things to just throw into the mix. One of them, to refer to Ed's hero, Rush Limbaugh, is that Rush probably decides what to say based on focus group or marketing research. And so I often and Ed, I respect your experience and your wisdom, and I think a lot of what you say is right. But I would just make the point that we shouldn't decide how to, describe our messages based on what we think. There is a, social science research can get us answers, and I think that we, should look in that direction. And obviously, it's going to be different for different audiences. But I think that, that kind of empirical approach will probably shed more light on it than, what most of us think. Although there are people who decide what they think based on, you've done some marketing research a lot more than many of us. So I wanted to make that point. The second thing is that on the question of, is healthcare a human right? I think that it's been a fraught sort of concept. And Ed, I emailed you about this. I was really interested to go back to the segment of the New York Times series last year, 1619, which was all about slavery and race, and find that one of their segments was called, "Why Doesn't the United States Have Universal Health Care? The answer has everything to do with race." And this is by a member of the New York Times editorial board, Janine Interlandi, who points out that, at least in her reading, that the term healthcare as a human right was coined by the National Medical Association back in the 1940s and 50s as a way of asserting that African Americans deserved equality, and that by linking their desire to be, their demand to be treated as human beings, this was the way that they expressed it in terms of healthcare. So I thought that that was really interesting, because our whole discussion about race is really changing. And I think that, to a young audience, saying healthcare is a human right it easily relates to the fact that African Americans and people of community of color are human. And then the third thing that I want to just throw in is that I think another way of expressing it, and I'd like your reaction to this, is to say, well, doesn't everybody deserve an equal opportunity to have health care? Because, this equal opportunity paradigm has, of course, been at the center of our whole battle over, racial equality for 150 years. And I think people are finally kind of turning in an overwhelming sense in favor of saying, yeah, people really do have deserve equal opportunity. So maybe that's a useful expression or way of, expressing the concept.
We do have our next speaker lined up, Ed, so maybe make a brief answer.
Sure. I'd say I agree that the plural of anecdote is not, the plural of anecdote is not data. So yes, we should do more market research and apply it. But that would cost something, so we should do that. The second is that the 1619 piece, tremendous series. I'm sure y'all saw it when it came out. I just learned a few days ago that there's a podcast, 1619, and it's terrific to listen to. In particular, you should listen to the one Hank was talking about, which is episode 4 in the podcast. So anyway, thanks.
Thank you so much. So I don't know, Ed, whether you would be available to go into a breakout room if people had more questions that they still wanted to ask you, or are people ready to go on to seeing David Belk's?
Yeah, no, I think we should go on to David Belk's.
Okay, great. Thank you so much, Ed. That was a wonderful presentation. It was great to have you answering questions for folks so much. That's wonderful.
Thanks.
And we look forward to having you back next office hours on the 30th. Thank you so much for agreeing to do that.
Okay, thanks.
Thank you.
Oh. And thank you, David, for coming back also. David has written a book called The Great American Healthcare Scam, and he gave a talk on the 26th, was it, about the first part one, we're calling it, and this one is going to be more about insurance and Medicare today, is my understanding. So David, thank you so much for coming.
Can everyone hear me?
Yes.
Oh, great, great, great. And can everyone see my slide right there?
We see it.
Okay, great. All right. Okay. So yeah, like you said, tonight is part 2 of The Great American Healthcare Scam, the book that I wrote, How Kickbacks, Collusion, and Propaganda Have Exploded Healthcare Costs in the United States. And much of what I'm presenting to you tonight is backed up by information on my website, truecostofhealthcare.org. And again, a couple of weeks ago, I presented part 1, which was about prescription drugs and medical billing. And tonight is part 2. Let's see if this works. It's not working. Oh, wait. Oh, health insurance. It's money for nothing when the risk is free. All right. So to recap some of the stuff that I said on the last presentation, because it is still important for tonight. On prescription drugs, remember I told you that 87% or 7 out of 8 prescriptions in the US are for generic medication, and most of these medications cost pharmacies only pennies per dose, meaning that contrary to popular belief, most prescription drugs in the United States are not very expensive. However, the insurance copay for most generic prescriptions are usually more than the medication actually costs, meaning that insurance companies, instead of helping people purchase these medications, if anything, tend to get in the way. Also, brand name medications, which are 1 in 8 prescriptions filled in this country, are insanely expensive, often 100 times the price of the generic medication, even for the exact same medication. Part of the reason they're so expensive is that pharmaceutical companies pay large rebates to the pharmacy benefit managers who choose which brand name drugs would be on which insurance plans, and these rebates are what are encouraging the runaway price inflation for these brand name medications. Also, medical billing. I mentioned that and showed repeatedly that medical billing costs, medical billing charges are insanely high, but often meant to be works of fiction, in that most insurance companies pay only a fraction of any medical billing charge on any medical bill most of the time. However, these insurance payments tend to be random, chaotic, have little to do with either the total charge or even the medical services provided on these bills. And insurance companies are using these inflated billing charges to hide the fact that they are purposely driving up medical costs whenever possible. They do this by overpaying in order to increase the revenue by leveraging the medical loss ratio. All right, so that's the recap. Tonight we will talk about private health insurance, what they're really up to, and Medicare. Okay, to begin with, I'd like to contrast private health insurance with other insurance. Okay, there are a number of ways in which they're fundamentally different. The 3 I'd like to highlight in the beginning are the facts that we tend to use our health insurance for every interaction with the healthcare system, which is very unlike other insurance. I mean, you would never use your car insurance to fill up your gas tank or change your oil or even overhaul your transmission. You don't use your homeowner's insurance to repair a broken window or pay your electric bill. You use your health insurance to buy a bottle of pills that shouldn't cost $3. You use your health insurance to pay for an x-ray that's, maybe $40, or a doctor's office visit that's, $65 or $70. Whereas you would never use other insurances for such trivial expenses. Health insurance also tends to be far more expensive than the other types of insurance we pay for. And we tend to receive health insurance as, at least if you're not on Medicare or Medicaid, you tend to receive your health insurance as an employee benefit if you have it at all, which, most other types of insurance you pay for yourself. Now, just to underscore the price, our health insurance, I get it from my wife. She gets it as an employee benefit. $22,000 a year is what's spent between my wife's employer and herself on our health insurance for a family of 4, which, with no medical conditions. Now, contrast this to my medical malpractice insurance. As a practicing physician, I actually pay less than $5,000 a year. And there's this belief out there, another myth, that medical malpractice is insanely expensive and breaking doctors. Well, I'm here to tell you that most orthopedic surgeons in California spend a lot less on medical malpractice than it costs to provide health insurance for a family of 4. So yes, health insurance is far more expensive than what we might pay for auto, homeowners, life insurance, or anything else. All right. And as an employee benefit, what most people are not aware of is the fact that most employers now are self-insuring using what are called administrative service only contracts. They're either abbreviated as ASCs or ASOs. On tonight's discussion and in my book, I use ASCs. So administrative service contracts, where the employer actually covers all of the healthcare costs with their own money rather than the insurance company for all employees. All right, they become increasingly popular over the last couple of decades. As this graph shows, so this is, again, from the largest private insurance companies that offer commercial health insurance. You can see a couple of things on this graph. So this is the total number of privately insured by these companies. And as you can see, that total number has not changed since about 2005. So for about a decade and a half, and in fact, in the United States, the total number of people with private insurance has not changed dramatically in the last 2 decades. Not the percentage, the total number, all right? But more importantly, the blue part of the bar on the bottom is the number of people these insurance companies insure directly, in that they pay for the appendicitis, the doctor's office visit, the healthcare benefits. The insurance company pays for it, whereas the green part of the bar shows the percentage of people, or the number of people, these insurance companies only cover through what are called administrative service contracts, where the person's employer pays for all medical costs. And as you can see, by 2017, 76% of all private health insurance was actually administrative service contracts instead of insurance. And this is a problem for a number of reasons that I'll go over tonight. All right. First, how do these work? So the employer sets up an account that belongs to the employer. All right. It's a bank account that belongs to the employer, and that the money belongs to the employer, but that the insurance company is free to write checks off whenever they need it. The insurance company uses that account that belongs to the employer to pay all medical claims, all right, that happen for the employees, all right, of that company. And then the insurance company is responsible to tell the employer only the total amount paid on all claims each month. So the only feedback the employer gets on what was purchased and how much was spent is the total amount, so that the employer can refurbish the account each and every month. They are not given any specific details most of the time on what medical claims were paid for and how much was paid on each medical claim. All right. So the reason this is a problem, all right, well, first, the apparent advantage to employers. The reason employers are going with these is that on the surface, they appear less expensive. The fees insurance companies tend to charge for administrative service contracts are only about $25 per member per month, which is certainly a lot less than the $300 to $600 per member per month that full insurance would cost. All right. Plus, it gives the employers the illusion of controlling their healthcare costs by supposedly eliminating the middleman. Unfortunately, and it also bases on the assumption that health insurance companies, the belief that health insurance companies will always strive to get the best deal on healthcare costs whenever possible. In other words, if the health insurance company is managing your healthcare expenses, even when it's with your money, they will always strive to get the lowest cost and be as parsimonious as possible. Well, if you paid any attention to my last talk, you should know that's not true. Health insurance companies, if anything, benefit from driving costs up. And now, with these administrative service contracts, they're basically operating on an unlimited expense account for which they're not really accountable to anyone. All right. So the reality is, what these insurance companies have managed to do is put themselves in a position of risk-free risk management. They are managing the risk of employee, healthcare benefits, which is what insurance is about. It's about risk management. But they don't assume any of that risk. They have no skin in the game. All right. They've offset all of that to the employers. And what's more, they have almost no accountability to anyone. If the employer wishes to look at the actual claims, which is an incredibly difficult thing for them to do, assuming that they would even understand these claims, were they able to look at it. I mean, I've gone over this with a couple of employers now, trying to, audit their claims. But somebody actually sent me an example of an administrative service contract for their company. And, here it says, at plan sponsor's expense, in other words, if the employer wishes to audit the accounts, they have to pay for the audit, right? The plan sponsor shall have the right to audit claims on Anthem Blue Cross Life and Health premises. In other words, they have to go there. They aren't sent them. They have to go there, look at them during business hours. And they are not allowed to have a third party with them to help them understand this unless the insurance company has signed off and approved of that person. In other words, looking at the specifics of the claims, how the health insurance company is spending the employer's money, is nearly as difficult as looking at Donald Trump's tax returns. So the insurance company has little, if any, actual accountability to the employer. They're spending the money of the employer basically with impunity and have written themselves completely out of all of the risk. All right. Put another way, instead of employers eliminating the middleman with administrative service contracts, they place the middleman in a position of absolute power with no accountability. All right. I think you can see why that would be a problem. Now, here's a graph I showed on my last presentation. And at the time, I was talking about the medical loss ratio and how private insurance companies are leveraging the medical loss ratio to drive up their costs. This is true. It's undeniable that health insurance companies do benefit from higher costs overall. And as you can see, the purple line is going up much more quickly than the yellow and green lines, which are Medicare and Medi-Cal, what Medicare and Medi-Cal spend for, in this case, it's for each hospital inpatient. All right. Private insurance companies, which insure the working well, spend a lot more money each year on hospitalized patients than Medicare and Medi-Cal, which cover the elderly, the disabled, and the impoverished. You'd think it would be the opposite, but as I said last time, private insurance companies benefit from higher costs. But another thing that's pushing this line up for the private insurance companies much faster is the fact that they really have no accountability for what they're spending. In other words, it doesn't matter to them how much they're spending. They benefit from higher costs. They have, no accountability for this, so they keep sending more and more money to the hospitals. And of course, as I said before, the hospitals aren't complaining. And so you might think, okay, why don't insurance commissioners get involved with this? If this is such a complete ripoff for employers, can insurance commissioners at least look in on it? No. And here's an interesting loophole in the entire issue of employer-sponsored healthcare. Employer-sponsored healthcare in general, since it is a benefit, is not covered by any state insurance commissioner whatsoever. Instead, it is regulated, use the term loosely, by the Employer Retirement Income Security Act of 1974, okay, ERISA. This was passed, obviously, in the early 70s as a law that was meant to protect, it was a law that was meant to protect pensions, all right? Basically, the entire focus of the law is to say employers can't liquidate pensions whenever they feel like it. which is a good thing. Unfortunately, ERISA says nothing or next to nothing about insurance at all, certainly not health insurance in particular. However, over the years, federal courts have decided that since this applies to employee benefits, it should be a blanket law that applies to all employee benefits. Since federal law supersedes state laws, there is no state jurisdiction over employer-sponsored benefits. And what's more, since the insurance company never physically possesses any of the money used for administrative service contract expenses, there is no state regulation whatsoever for any employer-sponsored health insurance, certainly not the ASCs. All right. In fact, none of the specific financial transactions that occur within an ASC are reported to anyone. Again, the insurance company never possesses the money, so it never makes it anywhere on their financial statements that they report to the SEC. Put another way, roughly 76% of commercial health insurance are these administrative service contracts, meaning that roughly $800 billion a year spent on healthcare is spent completely in the dark, unregulated, unmonitored, unaccounted for. I hope I don't have to explain to you why that's a problem. It's probably one of the greatest looming crises in healthcare, if not to our economy in general, that absolutely nobody is talking about. All right. And an interesting aside is how this relates to the Affordable Care Act, also known as Obamacare. All right. The insurance companies were livid about the Affordable Care Act, and everyone was like, why? This is giving them more business, and wasn't this a conservative plan? Well, it was a conservative plan in the 90s before the health insurance companies decided they wanted to get out of the commercial health insurance business. And this was the point. First, it did place a few minor federal regulations on all health insurance, which did actually apply to employer-sponsored health insurance. And the insurance companies were happy with the Wild West issue of no regulations whatsoever, since only ERISA covered them. But more specifically, what they disapproved of was the fact that it was attempting to draw the health insurance companies back into the commercial health insurance market. They were trying to get out of it. Remember, commercial health insurance is that blue bar that keeps going down, down, down every year. They're trying to get away from it. And the Obama administration said, hey, we'll pay you some money to, take on all these extra private clients. And they said, we don't want them. All right. Which brings me to the next subject. If private insurance companies don't want commercial insurance, who are they insuring? Medicare and Medicaid recipients. That's the customer base they are looking for. And this is really important. So this graph, remember, the graph before showed you that the total number of people with private insurance companies is barely changing. This is the number of privately insured Medicare and Medicaid recipients each year since about 2003. You can see it's gone up about 7 times over about a decade and a half there, right? The insurance companies are scrambling to sign up as many Medicare and Medicaid patients as they possibly can. And any of you who are on Medicare, I think you already know that, because if you're on it, you were probably harassed endlessly as you were about to go on it by the private insurance companies trying to sign you up. This graph shows the proportion of premium revenue companies that offer both private insurance and Medicare and Medicaid plans are getting from Medicare and Medicaid each year since 2003. You can see only just over 1/5 of their premium revenue came from Medicare and Medicaid recipients in 2003. Now it's almost 2/3 of their revenue. That's the business that they're after. And the four major types of policies.
David?
Yes?
Some people are having trouble seeing your screen, so I just want to take a second to make sure that everybody is able to do that, because it would be hard to read it if they couldn't have it on the big screen. So if you look in your upper right-hand corner, there's a couple of icons that let you choose what your view is. And there should be one labeled the speaker view. And if you click on that, then David's video of his face will be the same size as everybody else's, and his screen should be on the main screen. I can see his slides just fine, but 2 other people have commented to me that they cannot.
I think I just lost my mouse too. It says something about someone is requesting a remote control of your screen, and it says decline or approve, and I don't have any control of my mouse. What do I push? Can everyone see my screen now?
Okay, I can see your screen, and I can see a few heads nod in the window that I'm in.
Okay.
Can you nod your heads if you can see his screen fine? Okay.
All right. So
Mike, are you seeing it, Mike? You're muted.
I still don't have my mouse, so.
The owners and
there
co-hosts
it is.
probably can't see the screen.
Okay. Okay, so you can go ahead, David. I'm sorry for the interruption. Are you able to?
Oh, here it is.
Who's trying to take control of your?
Someone named Chuck. I don't know. Anyway.
Oh.
So let's go back to the types of private insurance policies they're selling Medicare and Medicaid recipients, because that's going to be most of the rest of tonight's discussion. So you have Medicare supplemental policies, also called Medigap policies, where a private insurance, policy covers your deductibles and co-insurance with Medicare, right? You have Medicare Advantage, where you sign over all of your Medicare benefits to a private insurance company to manage them for you. Part D plan covers prescription drugs for Medicare recipients, and then Medicaid Managed Care, which is a bit like Medicare Advantage, only for Medicaid patients, where private insurance company manages the benefits of poor people. All right. Okay. Now, you got to wonder, based on what you just saw, what about pre-existing conditions? Medicare covers only the elderly and the disabled. Medicaid covers only the impoverished. Isn't that a whole lot of pre-existing conditions? Why are the health insurance companies lining up to sign up all of these elderly, disabled, and impoverished people if they are so obsessed with never having any pre-existing conditions? Right? I mean, isn't that the largest pool of pre-existing conditions in the country? I mean, if you are about to go on Medicare, about 6 months prior, your phone will start ringing off the hook with insurance agents who want to call you, want to sign you up for any one of these policies. I bet you none of them even mentioned a pre-existing condition. You could be having chest pain while you're on the phone with the insurance agent. They will sign you up, no problem. And yet they won't take a 40-year-old with high blood pressure because it's a pre-existing condition? Really? So in order to understand what it is the insurance companies are up to and what they're trying to do.
Yes.
I'm going to sign off.
We need to discuss Medicare more specifically. What does it cover? How does Medicare cover what it covers? And what, if any, benefit are seniors getting from these extra private health insurance plans? All right. Now, in my book, I make this statement. Seniors with Medicare have about the best deal for their health care anyone can get in the country. Now, that statement in and of itself almost doesn't really say very much, because if you've been paying attention to what I've been saying, the private health insurance companies haven't been offering a very good deal at all. It's a pretty low bar to beat. All right. So I think tonight I need to get a little bit more specific. And I always start with hospitalization. Anytime I meet a senior with Medicare who's wondering about how Medicare covers anything, I ask them this question. If you have Medicare and only Medicare, and are hospitalized for 4 weeks, resulting in a $700,000 hospital bill, how much will you owe the hospital? It's a very important question. Just for your information, I don't think I've ever met anyone with Medicare who has answered that question correctly. And I've asked retired doctors, retired hospital administrators. It's very curious. I almost never get the right answer on that, even though It's not a difficult question to answer. I mean, it's right there on Medicare's website. If you answered 20% of $700,000 or $140,000, you're way off. You're not even in the right ballpark. As I've said repeatedly, billing charges are works of fiction. Medicare does not use works of fiction to determine payments. What you actually owe for that $700,000 hospital bill is the Medicare Part A deductible, and only the Medicare Part A deductible. For any hospitalization lasting up to 60 days, a Medicare recipient only owes the hospital $1,408, which is the 2020 Medicare Part A deductible, not 1 penny more. Federal law prohibits any hospital from going after you for anything more than the Medicare Part A deductible for any hospitalization lasting up to 60 days. And you can see that right on Medicare's website. I got the link right there for you. All right. In other words, if your hospital bill exceeds $1 million, you owe the hospital $1,408. If your hospital bill exceeds $1 billion, you owe the hospital $1,408. If your hospital bill is 3 times the national debt, you still owe the hospital only $1,408. It's not 20% of anything. Okay. Now, obviously, that's a relative, oh, and is 60 days enough? Well, the average length of a hospital stay in the US, even for Medicare patients, is only 5.5 days. We send open heart surgeries home in 5 to 6 days. We send liver transplants home in under a week. All right. 60 days is 11 times the average length of a hospital stay in this country. 60-day hospitalizations are about as rare as jackpot lottery winners. I'm not saying they never happen. They're really rare. All right. And here is an example. Now, the Medicare Part A deductible goes up about $30 a year, meaning 5 years ago, when this, for the date on this bill is 2015. 5 years ago, the Medicare Part A deductible was $148 less than it is now, $1,260. Here you can see this exactly what I'm talking about. Total charges on this bill, it was a 4-week hospitalization at Stanford, $711,000, right? And you can see, well, first of all, Medicare only agrees to pay $75,000, $74,958. You have $635,000 adjusted, completely disregarded, not paid by anyone to anyone. It's a work of fiction. And the amount due, the Medicare Part A deductible in 2015, $1,260. That's all you would ever owe if you have Medicare Part A and you're hospitalized, regardless of the billing charges. So this is easy to understand, and it's easy to look up. Yet, as I've said, I have yet to meet a senior who knew this before I told them about this. The vast majority of people who I ask will guess somewhere along the lines, if they guess anything at all, they'll guess 20% of the billing charges, which is obviously not even in the right ballpark. In the case of that bill, that's 100 times what they really owed. Okay, what about that 20%? The 20% coinsurance is for Part B benefits, but only based on Medicare's approved payment. And you really have to understand, Medicare approves about an average of 17 to 18% of billing charges in the United States. Now, that doesn't mean that Medicare's payment has anything to do with billing charges. It doesn't. It's just the average billing charge is about 6 times what Medicare actually approves for most medical services. And if you do a little math, the 20% you owe is only on the 17 to 18% that Medicare approves, which is actually about 3.5% of billing charges on average, which sounds like a lot less than most people think it is. All right? Bottom line, Medicare actually protects its recipients from medical overbilling far more than any private health insurance plan will. I wrote an entire chapter in my book on the many ways in which private health insurance companies deliberately throw people to the wolves financially by denying claims and leaving them on the hook for full costs. Medicare is the one program that for the most part doesn't do that. And yet, oddly enough, most of the seniors I've ever spoken to about this don't appear to know this. Now, two caveats. One, most preventive services and blood tests are covered by Medicare Part B for free, $0. All right, mammogram, free. Screening colonoscopy, free. Most blood tests, free. No 20% of anything. However, in rural areas, areas that are far away from population centers, there has been a policy in effect since the late 70s, unfortunately, that really does put seniors on the hook for 20% of full billing charges for certain services only in rural areas. The reason for this was in the late 70s, they wanted to attract more doctors to these areas. And at the time, billing charges averaged only about 15% more than what Medicare approved. Those were the days. Now billing charges are 500% on average more than Medicare's approved payments. So this really does leave seniors in rural areas sometimes on the hook for enormous medical bills. This policy needs to change. Obviously, it needs to be revisited. And unfortunately, like most of Medicare's policies, people aren't aware of this enough. But the vast majority of people, by definition, don't live in rural areas. They don't live far away from population centers. So this doesn't apply to the vast majority of Medicare recipients in the United States. Still, that policy needs to change because obviously people in rural areas are, if anything, less able to cover these enormous bills than, their urban counterparts. Okay. So if you're not in a rural area, just to give you some, some actual figures, the out-of-pocket expenses for, say, open heart surgery, start to finish, total, with Medicare, would be about $2,500. Here's a testimonial from one of my contacts. She actually put this up on the internet after reading one of my blogs about Medicare. Here she says, I did have a total knee replacement in 2012. Well, looking over the payments made, I found that Blue Shield paid a total of $1,100 from pre-tests to the last physical therapy and everything in between. So the entire total knee replacement, Blue Shield only paid $1,100. That was her Medigap policy. Medicare paid everything else, including the surgeon who billed Medicare $20,000 and was actually paid $858. Not unusual at all. So without her Medigap policy, she realizes she would have only owed $1,100 for everything on that total knee. Still, after presenting all of these to Medicare recipients I know, I often get this question. What if I have a catastrophic illness? Now, the word catastrophic obviously implies a lot of horrible things without any specifics. So I decided to add some specifics. And I took a patient of mine who had what I think you'll all agree is one of the most catastrophic medical issues you will ever encounter, or at least that I ever encountered. All right. So this was a patient of mine I diagnosed with liver cancer in December 2015. Yes, liver cancer. Over the next 2 years, she received chemoembolization. So her chemotherapy was directly injected radiologically into her liver, radiofrequency ablation, and a liver transplant. Yeah, liver transplant. In addition, she had 2 subsequent hospitalizations after the transplant due to a complication. She spent a total of 42 days in the hospital in 2017. Add to that all the outpatient tests, office visits, preoperative, postoperative care, including all the MRIs, ultrasounds, blood tests, you name it, etc. All the doctors, surgeons, everyone who saw her in the hospital when she was hospitalized, all of that. And I'll even add 61 sessions of psychotherapy and 16 sessions of physical therapy for issues unrelated to the cancer or the transplant. She brought me all of her bills for that entire 2 years. So this entire enormous conglomerate, I added up everything. Okay, all medical expenses. All right. So this all happened in 2016 to 2017. She's actually fully recovered now. Since the end of 2017, she's been fine, only a few follow-up visits and blood tests to monitor her new liver. But during those 2 years, she endured a total of 330 individually billable medical services, including the 3 hospitalizations. Is that catastrophic enough? All right. So the billing charges, how much did this cost? The billing charges, which are works of fiction, for all of this medical care did exceed $1 million. However, Medicare only approved about $180,000 in total payments for all 330 medical services, including the 3 hospitalizations. In other words, only $180,000 was paid to anyone, by anyone, for all of this medical care, which I think you'll agree is probably more than most people will ever need in a lifetime. So $180,000, 20% of that is $36,000. Does that mean that the co-insurance was $36,000? No, and this is important. All 3 hospitalizations were covered under a single deductible. In 2017, it was $1,316. Why? Because you don't owe a new deductible until your benefit period ends. And your benefit period doesn't end until you've been home for 60 days. In other words, they cover up to 60 days hospitalization, but before a new benefit period can start, you have to be home for 60 days. Well, she got her liver transplant in early July, goes home for about a week, gets a complication, gets hospitalized again for 4 weeks, goes home for about 6 weeks, which is not 60 days yet, gets hospitalized again in October for about a week. So she gets hospitalized for a total of 42 days between July 1st and the middle of October. And the total that would have been owed by this patient, for all 3 hospitalizations was the deductible, Medicare Part A deductible, $1,316 one time. And what's more, that would have covered 20 extra days in the nursing home at no extra charge as well. So more than $700,000 in hospital bills, $1,316 is all she would owe. All right. So the grand total in coinsurance and deductibles over the entire 2 years for all 330 medical services was $15,480. All right. That is a good amount of money, enough to buy what, a used Honda Civic? You have to admit, it's less than 1/10 what most people would guess you would owe if you had Medicare and only Medicare for all of that medical care. And this is important because far too many people with Medicare assume that their bills with Medicare only would bankrupt them for a lot less medical care than this. They see that $400,000 hospital bill, they assume $80,000. They say, I can't afford that. But they're wrong. And this is the problem. Seniors really need to know how good their coverage is. Most of them don't understand it. All right. And the reason has a lot to do with these private insurance policies. So we'll start by discussing supplemental coverage or Medigap coverage. What is the cost of these plans and what actual benefits are provided to seniors for the Medigap policies? So first, cost. Almost none of the seniors I've ever asked who have Medigap policies are able to tell me exactly how much they pay. The reason for this is that most of the time when they sign up for these policies, they sign up for an automatic deduction of the premiums, either from their bank account or from their pension checks. And they long ago lost track of how much is paid. So I will ask them, could you go home and find out and tell me? And usually when they do this, they're rather shocked. And the reason they're rather shocked is that in most states, not every state, but in most states, the year after year after you turn 65, they start you off at one low rate, but then it's almost like a oh, can you hear me? All right, sorry, I lost my connection there for a second. All right. They start you off at a low rate, but then those rates go up very quickly as you age. Here's an example. So this is from Blue Shield of California. They've gone down since then. In fact, I can assure you they haven't. All right. So first of all, you got 7 different plans to cover basically 2 deductibles and co-insurance, all right? Which of course adds to the confusion. I mean, that's one of the #1 techniques of insurance company. They like to confuse you so that they can rob you. But I have circled here. So if you're looking at the Plan F, all right, the fee for the Plan F when you're 65 to 66 years old. Now, the Plan F is the Cadillac one that covers all of your co-insurance and deductibles, so you end up paying nothing. And so it starts you out at $133 a month. But by the time you're 71 years old, if you can see that, the rates have gone up to $212 a month, which is a 60% increase, all right? And people lose track of that. That is a huge amount of inflation over 6 years. Now, $212 a month, that's $2,544 a year, which means by the time you're 71, you're paying enough in Medigap premiums, if you have this Plan F from Blue Shield, to cover an open heart surgery each and every year, 2 new knees each year. Remember, that woman had said only $1,100 was paid on her total knee. So that's 2 new knees each year, which is a great deal if you're a centipede. A new liver plus all the extras every 6 years for liver cancer. How many livers do you need? All right. As you can see, for what you get for these policies, they're rather pricey. Benefits. Medigap plans tend to cover only deductibles and co-insurance costs determined by Medicare. And this is rather important, okay? They don't cover uncovered expenses like long-term care unless you pay a lot extra. They wouldn't cover, like, if you ran out of lifetime benefits. There is such a thing with Medicare. It's pretty rare, but they wouldn't cover that either, okay? They only cover your $1,408 Part A deductible, your $190 Part B deductible, and your 20% coinsurance on Medicare-approved rates, okay? And what's more, they don't determine any of those payments. In other words, the administrative costs we often associate with insurance companies of determining what payments ought to be, determining what benefits ought to be, they don't do any of that. The entire purpose of a Medigap policy is that they write checks that you yourself could have written for amounts that are usually pretty trivial. And the minimum loss ratio on these plans, unlike the 80 to 85% minimum loss ratio that you often get with other health insurance, the minimum loss ratio for Medigap plans is 65% for individual plans and 75% for group plans. What does that mean? You go to the doctor and the office visit, Medicare says, well, that's worth $75. Medicare covers 80%, that's $60. Oops. Hello?
David, I'm sorry. Can you share your screen again?
Oh, sorry. I lost the whole thing. Let's see. Let's see if I can just go back into. Are you still there?
We hear you.
You can hear me, but I just lost it.
I see you too. Oh.
Yep, that was my mistake. Please.
How do I get back onto this?
You're on.
Oh, there it is. All right. It just disappeared. All right. So I share my screen again. Share. That's it. All right. Play. Okay. So the Medigap plan pays your 20% coinsurance, but that's all they do. They don't determine any payments. They have zero administrative costs whatsoever. So you go to the doctor, Medicare says that doctor's office visit is $75. Medicare pays $60, that's the 80%. You would normally just write a check for $15. Not difficult to do, but instead you pay the insurance company on an average loss ratio of 75%, meaning you pay the insurance company $20 so that they cover that $15 expense. You get an MRI. Medicare says that MRI is worth $600. That's all the provider's going to get. Medicare covers $480. They're 80%. Normally you'd pay 120 bucks. That's your 20%. All right. But instead you pay an insurance company $160 so that they can cut a check for $120 that you could have more easily paid yourself. You're paying a huge margin to an insurance company to do nothing but pay Medicare providers for Medicare approved services at Medicare rates. They do nothing to determine anything. Why do seniors meaning Medicare plan, with a 75% loss, and if it's a 65% loss ratio, which you get with the individual plans, that's a 50% commission. You're paying for an insurance company to do nothing more than write checks you could have written yourself more easily. Why are they so popular? Well, I hear it over and over again. Hey, look, last year I was hospitalized for a heart attack, ran up a $300,000 hospital bill. I didn't know anything. They have no idea how inexpensive their health care would be with Medicare alone. Far too many seniors, the majority of them, believe that Medicare alone would leave them bankrupt for relatively trivial health care costs. And they need to stop believing that. All right? Because right now, Medicare does all of the work, pays almost the entire bill, and is getting almost none of the credit. And I hope you're seeing how these policies are undermining Medicare. In fact, I hope you're seeing how these policies are undermining everything you're trying to accomplish. Because if people believe that Medicare easily leaves them potentially bankrupt for relatively trivial medical costs, which it doesn't, then you can see why a lot of seniors would be at best lukewarm about the Medicare they have. Well, okay, it's a good plan, it's a nice plan, but it's inadequate. In the minds of all of these seniors, it's phenomenally inadequate because they have no idea how good Medicare is, because these private insurance plans are hiding that from them. And I know this from talking to seniors all over the place. They assume that Plan F at $200 a month is a good deal, when in fact, unless they're getting open heart surgery every single year, it's probably not. All right. Now, Medicare Advantage, another one of the plans. Well, it takes advantage of seniors. I mean, come on, it's in the name. The purpose of Medicare Advantage is to funnel Medicare money, CMS money, through the private insurance companies so that they can keep a cut. All right. It's basically a way of infiltrating Medicare. Medicare, as it is run, embarrasses the insurance companies. It doesn't compete with them. It embarrasses them for what it offers and the price that it does. But if the insurance companies can tap into that seemingly endless supply of federal money, well, they're perfectly happy with Medicare as long as they can manage it in their own way. And what is their own way? Well, they bottleneck healthcare services. They add massive amounts of confusion. I mean, the number of Medicare Advantage plans that you can get in any different state, all the different co-pays that you have. I mean, you saw how simple Medicare was. A Part A deductible, a Part B deductible, a 20% coinsurance. Well, you have dozens of different Medicare Advantage plans offering dozens of different services in dozens of different ways, and of course, networks. Okay? I mean, what's the purpose of a network, right? Insurance companies originally set up networks so that they could get a discount from various providers who are willing to trade a little extra money on their fees with a large volume that the insurance company would send them. Well, with Medicare Advantage, the providers are treating Medicare patients for Medicare approved fees, for Medicare approved services. What is the point in having a network? It doesn't offer anything other than confusion and the risk of seeing a out-of-network provider or being taken to an out-of-network hospital if you happen to be in a coma and paying a lot more. So the networks by Medicare Advantage offer no advantage to anyone, only the risk of increasing your costs and the confusion. And of course, you have all the unnecessary authorizations because God knows we don't want people getting too many colonoscopies because they enjoy it, right? So they increase confusion, increase costs, bottleneck services. Well, what's not to love, right? However, they do offer prescription drug benefits and sometimes gym memberships. And while we're on the topic of prescription drug benefits, let's talk about Part D plans. Okay, so Part D plans offer prescription drug benefits. And it is the one private Medicare policy that seniors sometimes need. And I do stress sometimes. So before we discuss that, we need to talk about the Part D penalty. Seniors are often warned by these insurance agents of that horrible penalty. They never tell you how much because the word horrible scares you and the actual amount wouldn't. It's 1% of what's called the national base beneficiary premium or average premium cost each month you delay. That amounts to a horrible $3.74 per month each year you delay. That's right, less than $4 a month extra every year you delay. So if you delay 100 years, it's $374 a month. In other words, it's something most people could afford. Can you hear me? Oh, okay, great. My internet went out a little bit. Okay, so the penalty is not horrible. The price, again, they add a lot of confusion. You have multiple, in most states, you have multiple different Part D plans offered by several insurance companies, all right? And the price range can be anywhere from $10 a month for plans that virtually cover nothing to over $100 a month for plans that do cover a lot, but they're quite expensive for what you're getting, all right? The benefits. I can tell you right now, the vast majority of Part D plans will give you no help whatsoever with any generic medications. Unless it's a Cadillac plan, you will get absolutely no help, which you wouldn't notice. Medications don't cost anything, right? So, for example, let's go back to my liver transplant patient. As you can imagine, a liver transplant patient would need a lot of medications. She needed over 24 prescriptions. She had a plan called Silver Script, cost her $28.50 a month. All right. However, all of the prescriptions she received, all 24 prescriptions she received, were for generic medications. I see this a lot now. All right. And what's more, her anti-rejection pills, which are generic and not that expensive, they were actually covered by her Part B benefits. She didn't even need an extra Part D plan for her anti-rejection medications. However, how much she paid for all of her medications that year in copays, how much her insurance contributed, how much her insurance paid for each of the medications she bought, and how much the pharmacy paid for each medication she bought the month that she bought it. All right. Now, her insurance, on average, paid less than half as much as she did for 21 of her medications. In fact, they paid exactly nothing for 8 of them. Her insurance paid a total of $110 for those medications, whereas she paid more than $250 in copays, and these were medications that the pharmacy got for only $212, meaning she paid more than twice as much as her insurance company did, and her copays more than covered the cost of the medication to the pharmacy. Add to that the $340 she paid in premiums. She didn't get a really good deal on those medications, but she did have one very expensive medication. Because she was a liver transplant patient, most transplant patients are prescribed a medication called valganciclovir, generic Velcyte. Even though it's generic, it's still rather pricey. And the reason that it's rather pricey is that the brand name version is more than $80 a pill. And it had only become generic in recent years, which means, well, so she comes to my office in September telling me, well, there's one medication that I don't get much help with. I pay a $1,200 copay. That's what she told me. $1,200 a month she was paying for her generic valganciclovir. All right? Just that one medication. Everything else was cheap because the medication didn't cost very much. All right. So how much did it cost without insurance? Well, I spend about a minute going online, looking up the lowest cash price, and I get this coupon. This medication that she was paying $1,200 a month for with her insurance, she could have purchased at Costco for $844 a month. In other words, her savings without insurance would have been $350. They gave her, not only did they give her absolutely no help, as I've said often, they actually made it harder on her, which is not unusual. As far as Part D plans are concerned, they're run by pharmacy benefit managers. No rebates equals no help. There are no rebates paid on any generic medication, including expensive generic medications. Since there are no rebates, PBMs have absolutely no motivation to help you purchase them. So if it's cheap, they'll let you buy it for maybe a little bit more than it costs. If it's expensive, you're on your own. Okay. However, they do help seniors purchase brand name medications. Sometimes. Sort of. Here's the problem. If you're not currently taking a brand name medication and you purchase a Part D plan with the assumption that you might need a brand name medication in the future, there's no guarantee that the plan you bought that you're paying for now is going to actually cover the brand name medication you need in the future, because all of the formularies are relatively incomplete. Meaning you might buy a plan, pay all that money in premiums for it that isn't helping you at all, and then suddenly the doctor gives you Eliquis and you find that Eliquis is tier 3 or tier 4 or whatever, and if it's covered, it might be over $1,000 a year or even $2,000 a year in your copays and deductibles. Great. All right. So it's a little like, I like to use the analogy, you know, when you're buying a Part D plan, because the coverage for brand name is so incomplete. And you know, the generic medication prices are so low, seniors assume that their insurance is giving them help, which it's not. Meaning the vast majority of medications they're purchasing, they're not getting any help with it at all. And the brand name coverage is so incomplete. It's a little like buying a homeowner's policy that covers fire insurance, but only if the fire starts in a certain room or at a certain time of day. Okay, this is the kind of coverage you get with Part D plans. All right, and what's more, the pharmacy benefit managers who are running these Part D plans are primarily responsible for this runaway inflation in brand name medication prices. In other words, when you purchase a Part D plan, they allow you to benefit from their 40% rebates. So you get a discount, plus they get federal money to help them purchase it. But the fact of the matter is, it's the rebates that have been encouraging the runaway inflation of these brand name medications. So the end effect of the Part D plans is that they've made medications overall far less affordable for seniors. So really what I always tell people, your best option with a Part D plan, postpone buying it if you're not on a brand name medication. If you're given a brand name medication, that's when you sign up for a Part D plan and pay the fine. You will probably save money in the long run if you do it that way, because when you are prescribed a brand name medication, you can go online and see what your copay, your deductible, and your premiums will be, and you can find the plan that covers that brand name medication for the lowest combined price of copay, deductibles, and premiums. If you don't do that, odds are you will end up paying far more for that brand name medication otherwise. It's not a good deal, but it's probably the best deal you could actually get, because these plans are so confusing, so convoluted, and basically so corrupt. All right, so the summary is all three of these private plans with Medicare for Medicare recipients increase both costs and confusion for those who have them and provide very little actual benefit. In fact, my advice is always go with a Part D plan if you're on a brand name medication. Otherwise, all you need is Medicare Part A and Medicare Part D. And this is what seniors need to know. Because my conclusion for this whole thing if you wish to accomplish anything in reforming healthcare, the first thing you must do is take back Medicare for seniors who have it. Seniors need to know not just that they have the best deal in the United States for their health care, they need to know why. They need to know how much they really owe on those hospital bills. Because right now, the private insurance companies send out financial advisors to all these senior centers and all these seniors organizations with half-truths and warnings and talk about horrible, horrible consequences in bankruptcy if you're not, buying all these private plans. It isn't just that they're making a huge amount of money off of these plans. They are. It's that these plans infiltrate and undermine Medicare directly. And by undermining Medicare directly, they're undermining everything you're trying to do. You're trying to sell Medicare to everybody, and the seniors who have it think, well, it's nice, but it's inadequate. Well, that means you're trying to sell inadequacy to everybody. Okay, it's not true. And the problem is, if people are confronted with a choice of a system they know that's bad and overpriced versus a system they don't know that appears inadequate to them, they're going to side with the devil they know. I mean, you can always point to the UK and say, look, the UK and Canada, they got this nationalized health service work great for them. Well, I'm sorry, but unless you've lived in the UK or Canada and utilized their healthcare service, you're not going to know how well it functions. So when the insurance companies want to say, hey, look, you got to wait 6 years for a hip surgery. You need a note from the Queen to get aspirin. When they say things like that, people don't know what to believe because they've never used it. Yet you have tens of millions of people here in the United States with Medicare who are unfortunately rather lukewarm about it because they think Medicare will leave them bankrupt without all this private insurance. Well, the truth is they ought to be red hot about it, saying, wow, this is the best deal I ever got. But they don't know this because so many of them have been talked into these extra policies, which are huge money for the insurance companies and directly undermine everything you're trying to accomplish. Now, if you do succeed in convincing all of the seniors who have Medicare what a fantastic deal they have by teaching them how to read bills, what their actual responsibility to the hospital would be on that gargantuan hospital bill, okay, how trivial their expenses are compared to how much they're paying for their insurance company. You don't have to say, hey, drop your insurance. Just say, look, this is how you read a Medicare statement. This is what was actually paid. This is what you would have owed. And by the way, get them to look up how much they're paying in premiums for their policy, how much their costs would have been with Medicare versus, with that other plan, right? If you convince seniors of what I'm telling you, you will have tens of millions of Americans who, in my mind, are currently lukewarm about Medicare, suddenly red hot about it. And they'll be angry at the private insurance companies for lying to them for so many years and for robbing them for so many years. Not only that, if enough seniors start dumping their extra policies, you're going to deny the insurance companies a huge source of revenue that they are currently using to oppose you. How good would that be? So bottom line, if you can't sell Medicare to Medicare recipients, don't expect to sell it to anyone else. You've got to get the Medicare recipients on board with what they really have. Oh, and last point, AARP. You may not be aware of this, but AARP has had a partnership with United Health Group since 1998. That's right, for 22 years now, AARP has been representing health insurance far more than it's been representing seniors. They are chief among those sending financial advisors out to all the senior centers to talk with them about all of the horrible, horrible medical bills they will be having with Medicare alone. And you really need to expose AARP for what they truly are. They are an advocacy group for United Health. They do get your free coffee at McDonald's, but beyond that, they are an advocacy group for United Health. They are not an advocacy group for seniors. obviously they lobby to support Medicare. They have to. The main, a main source of business for United Health Group is Medicare recipients. So if they ran out of Medicare recipients, who would they sell those policies to, right? You can't rob someone who's broke. All right. So I think I've gone over my time. Questions?
Thank you, David. That was a lot of information. We very much appreciate all the research you've done and organizing it for us. So let me see what we have. I don't see people's hands raised yet.
There's Robert.
Bob Wickland's got his hand up.
Okay, so not in the participants list, just physically. Let me get a different view so I can see hands that way. Let's see here.
I'm sorry, I don't see where it says raise your hand on the thing underneath. I'm sorry.
Okay, so when you look at the bottom line where it says participants, if you click on that icon where it says 28 participants, then you'll get a bar at the side. And well, actually, since he's still screen sharing, it won't be at the side. It'll be a pop-up window in the wherever it pops up.
Can I get out of the screen share or something?
Yeah, that'd probably be good.
All right.
So,
I'm sorry. Could I just ask the question since you've already called on it?
Absolutely. Go ahead. And then after you, I will explain so other people can find it. Go ahead.
I'm sorry. Do you agree, like I do, that the Democrats that are supporting Obamacare as a legacy, which is really just private health care, do you agree that when they say things like, we can't afford Medicare for all, or they just want you to get rid of everything and start all over again, which is really foolish because we have Medicare, which is 54 years old and all of that. But my feeling is like the people like even Biden and Klobuchar and go on down the list of Democrats who are not really supporting Medicare for all. Is it because they really don't understand anything? They're ignorant about the Medicare for all legislation. Are they just lying to us? Or are they just wanting the campaign contributions of the insurance companies and the pharmaceuticals? Because I don't understand why they would say something like that. And the other thing that I just want to mention, do you all ever talk to people and ask them, like I've asked some people at what I call Congress people, and I asked the people there, the person that answers the phone, are you a socialist? And they, oh, heavens no, just like even, it doesn't matter. They'll say, no, I'm a capitalist. But does anybody ever say, didn't you go to public schools or did you just go to private schools all your life? Or have you ever used a fire department or called a policeman? Or have you ever gone to a public park or gone to a national park? Because all of that is socialism. Have you ever been in the service and got stuff from VA? That's socialism. And I don't ever hear anybody, even Bernie or Elizabeth, when they were asked point blank about socialism, they never said, we benefit from socialism every single day in this country. And you mention public education or the VA to somebody, and they'll say, I just don't, like you said, I just don't want to pay for somebody else's health care because they might take away mine. Okay, what do you say to people when they come to you with that terrible, dirty word, which I once said, socialism is a dirty word when it helps the sick and needy, but rationalized when it's disguised as tax cuts, tax breaks, loopholes, subsidies, buyouts, and bailouts for the rich and corporate greedy. What do you say to the people who think socialism is a dirty word when we're all socialists? If we've ever witnessed social services or anything that says public before it is usually a social service because a city, state, or county government has decided to use your tax money to pay for services for the public. What do you all say?
Well, I don't. I mean, arguing against something like socialism, it's a little like arguing about religion. It doesn't really get anywhere with most people. People have these names and they have these, beliefs that they associate with the names. And, if you say socialism, you might as well say you're a Satanist to certain people, and they're just going to tune you out. So it's good to avoid those labels unless you're talking to somebody who believes the way you do. But in answer to your first question, okay, why don't the Democrats push this? And because they know they'll fail, all right? And that sounds, rather glib, but you have to understand, Lyndon Johnson had 68 Democrats in the United States Senate when he managed to pass Medicare. He had almost 300 Democrats in the House, all right? And that's the sort of super majority where he could have gotten a constitutional amendment straight on party lines. It's not something we've had since then. We don't even have a majority now. And, the most, delusionally optimistic projection, Obama did not have enough for cloture because, again, keep in mind, John Kennedy had 64 Democrats in 1962 when he failed to pass Medicare, okay? Harry Truman had over 60 Democrats in the United States when he failed the first real national attempt to pass a nationalized healthcare system, all right? There's a huge political graveyard of people who've managed to do, people who've tried to do this, including, all the way up to Jimmy Carter, all right? The number of people who have tried, and Obama, he managed to get Joe Lieberman peeled away from him, all right? Ted Kennedy died. All right. He almost had a Medicare expansion, but then all of that was deprived of him. Now, at the time, he got a maximum of, at any one time, of 59 senators. All right. That's not enough for cloture. The Republicans will always block this if they have at least 40 senators. And then even if you do have fewer than 40 Republicans, you still have to sell this to Joe Manchin, and you still have to sell this to Tester in Montana, okay? And this is the problem. In order to pass a bill like this, you need the numbers to do it. And again, seniors vote. Maybe you'd have a chance to do this if you got all the seniors on board. But this is why I'm telling you what I'm telling you. Get seniors themselves more excited about Medicare. You might start to get the numbers in the House and Senate. Hello?
I said, why couldn't they have gotten rid of the filibuster?
Well, that works both ways. The Republicans take over again, and then suddenly the Democrats can't block anything. That's the fear. Oh, I lost you again.
The Republicans did it, and they're doing great getting Supreme Court.
Well, they haven't done it completely yet.
We have two people waiting to ask questions. Two
All right,
people.
okay.
Chris Allman and then Jerry Reed. Unmute, Chris.
Okay, can you hear me?
Yeah.
Yep.
Okay, so I am a retired physician. I went through a training last year to become a state health insurance benefit advisor, a SHIBA. These are volunteer positions that are to help Medicare beneficiaries choose plans when they first enroll. And if they make changes downstream or have complaints that might be going on. I'm telling you, if you ever want to learn how messed up Medicare is, I would suggest you do it, although COVID's changed everything, as has the new way that all Medicare beneficiaries now have to have their own account to sign up. So that's one point I'd like to make. Oregon has over 50%, 55% in the metro who are signing up for Medicare Advantage plans. Why? Because the premiums are onerous, as was described. And one of the things, though, that no matter what, is I tried to think about how a person would use a crystal ball to think about how to make these decisions, because one of the selling points of the Medicare, traditional Medicare, was, oh, well, if you like to move, to travel, you should really go for a traditional Medicare and get one of the Cadillac Medigap plans, which are really, really expensive, and blah, blah, blah. Again, when somebody comes in and they are over the low threshold of poverty where they might get help, they're left with absolutely no challenge. And I might add that it is really a relevant issue because, as was described, the out-of-network kind of features of surprise bills, I think, are going to explode in Medicare Advantage plans. Right before open enrollment, everything was changing in terms of which Medicare Advantage plans, hospitals that they would use. So when we were thinking, oh, these are the hospitals that this Medicare Advantage plan would use, all of a sudden that was changing. And the other thing that's a big lie that goes along with the AARP scam is that they are theoretically the only what is called community rated plan in Oregon, as is true in many states where they theoretically pool everyone together. You're one big pool and you think, that is gonna be the charge that I'm gonna have as I age. There are different ways that they rate how insurance plans are charged as you age. The index attained age is what is most typical. So what they don't tell you is that in many states, Oregon being one of them, that they have a slippery way that they actually do apply this attained age thing through, quote, discounts that they give you when you're at 65 at enrollment that go up every year. And the last thing I will just say is Medicare, AARP, there's class action lawsuits in regards to how they have milked through their relationship with United Healthcare to basically fund the organization by what they charge with their Medigap plans. All in all, you know, it's one of the reasons why, however you sell Medicare for all, it's like, oh my God, does it have to improve? So I just wanted to make those comments. I appreciate that this kind of way that this is being brought forth to a lot of physicians to talk about, because it's so complicated, and it's really annoying to me, because I just think, I don't know how seniors are signing up at this point right now, because the Sheba office is essentially shut down. So it's all by phone calls and they have to be on the internet. You know, it's sad, really sad. So that's all I have to say.
David, do you have anything you wanted to comment on that?
Well, I just, you know, I always like to put it this way. Medicare is not perfect. You can certainly find flaws in Medicare's coverage, but I always say going to a private insurance plan to make up for the problems of Medicare is a little like moving to Beijing, China to get out of the smog and pollution in Seattle, or the smog and crowding in Seattle. It's really, the private insurance companies are adding so much confusion. And I don't think Medicare is confusing at all. I have been dealing with Medicare for, you know, going on 2 decades now. I'm a doctor. I deal with it every day. All right. I dealt with all of that woman's bills. I have been, you know, analyzing exactly how Medicare covers. $1,408 Part A deductible, $192 Part D deductible, 20% coinsurance. That's it. And not only that, Medicare puts every single one of their approved fees up on their website. If you know the billing code, you know how much Medicare will pay. You know whether they'll pay, you know how much they'll pay. You contrast to the insane confusion that I was showing you on those medical bills on my last presentation. All right. Medicare is very simple if you ignore the insurance agents and just look at what Medicare covers and how Medicare covers it. $1,408. That's all you owe hospital. $192 Part B deductible. That's once a year. Then 20% coinsurance. And, you know, if you have an Advantage plan, you're still paying your Part B premiums anyway. And I don't see how these plans really save most people any money.
Can I just make a point, David? You had talked about you don't pay more than that one deductible. That's if you, because that's a 90-day period. After 90 days of having been into a hospital or skilled nursing facility, it's a brand new enrollment. And so that you can have new deductibles every 90 days.
But the fact of the matter is, far fewer Medicare patients are being hospitalized each year. I have that on my website. And, you know, the average Medicare recipient only gets hospitalized about 3 to 4 times while they have Medicare. And what's more, if you're going to get hospitalized twice in a year, it's far more likely to be the sort of scenario my liver transplant patient had, where you're rehospitalized because of a complication of the first hospitalization, which means you don't go home for the 60 days, which means you don't start a new benefit period. 2 independently separate hospitalizations for a Medicare recipient in a year are relatively rare, okay? I mean, we're using hospitalizations for a lot less than we used to. Overall hospital censuses have been declining since the 1980s, and they've been declining for Medicare recipients since 2005. So although, yes, you could be stuck with 2 separate deductibles of $1,400 each, all right? You're never on the hook for 20% of the hospital bill, which is what far too many Medicare recipients believe. And it's a very, very rare scenario indeed.
We have Jerry Reed and Barbara with their hands up.
Dr. Belk, thank you. That's a very good presentation, a lot of good information. I frequently talk to people who believe that they would have difficulty getting a doctor to be their healthcare provider if they don't have either a healthcare advantage or Medigap insurance in addition to their Medicare funding. And so I guess my question is there any reason, financial or otherwise, why doctor would prefer patients who have Medicare Advantage or Medigap funding over just plain Medicare program?
Well, first of all, you get paid not 1 penny more as a doctor if the patient has a Medigap plan or not. The only difference is the Medigap plan cuts you that $15 check instead of the patient. That's it, okay? The amount you get paid for seeing a patient who has Medicare with a Medigap plan is exactly the same as the amount you would get paid otherwise. In fact, I've had a couple of Medigap plans that actually tried to reduce their coinsurance, which is insane, okay? But Medicare Advantage, by law, doctors aren't supposed to accept Medicare Advantage if they don't accept standard Medicare. So again, you know, I always say if somebody rejects you because they don't like your form of Medicare, report them to CMS, because they shouldn't be doing that. Number one, hospitals will never do that. But you know, as far as the other doctors are concerned, doctors are as misinformed as anyone. But no, doctors don't get paid extra if you have a Medigap plan at all.
Is there any other reason why they would have that kind of a bias?
They've been conned.
Okay.
I mean, this whole thing is a huge amount of propaganda and misinformation. And, you know, Medicare is suffering from, I mean, it is being literally undermined by all of this misinformation.
Okay, thanks.
At every level.
That's good information. It helps me be ready to handle that kind of attitude.
I mean, everything that I'm telling you is on Medicare's website. So, you know, I mean, there are links to it on my website. If you just look up, you know, under the heading Medicare, you know, I have a whole thing on supplemental insurance, the liver transplant study, you know, the whole thing on Part D, and I link Medicare's website all along. So you can look it up yourself. You don't have to take my word for it. And taking people's word for this is, you know, part of the problem part of the reason we're in the trouble we're in. Too many people have been accepting what they hear without looking this stuff up. Please look this stuff up. It's on Medicare's website. It's linked to my website.
Thank you.
Thank you. And Barbara, you had a question?
Well, first I want to thank David Belk, because I thought that was really shocking to me, because I didn't know. I'm on Medicare, and really important information. And if we can communicate that information effectively, I think it could make a big difference in this. But I also want to suggest, in answer to the question of why the Democrats don't filibuster and why there are so many Democrats who do not support Medicare for all, people should look up the definition of the word neoliberal, because under Bill Clinton and since then, the party changed its spots. And it is now the party of neoliberalism, which is a philosophy which is entirely posited on the fact that private enterprise is the only way, the best way to get things done. Everything possible should be privatized. And the whole DNC, I mean, the whole leadership of the Democratic Party until AOC and Jayapal and the new, thank goodness, you know, the Bernie Sanders, who has gone along with them, but he's always, you know, stuck to his socialist framework. But until then, this party was no longer, and I think that's why we lost the darn elections to this idiot Trump, because people were so unhappy with the policies that neoliberalism has led us to embrace. I mean, you know, there was so much insecurity and distrust. Anyway, look up neoliberal and know that the DNC and the Democratic Party for the last, since Bill Clinton, has been no longer the Democratic Party that FDR, but a totally different beast, the party of neoliberalism, and there's a push to reform that and change that now. And I'm sorry if I sound windy, Mike. I'll be quiet now.
We have 2 minutes left for 2 questions.
Oh, sorry.
Okay, and thank you. And Barbara? Barbara Pearson?
Barbara Pearson, yeah. CMS Medicare Advantage. I have friends who say, how do you get traditional Medicare? And I've been on the Medicare site, and it's like the 4th choice is Medicare, traditional Medicare.
I know.
And it's, you know, it's insane until there's a change at CMS, because they're trying to get rid of it.
Well, that's the whole point. I mean, the Medicare bill that was passed by Congress in 2003 made all of that happen. And that is, you know, one of the things, I mean, the whole, you know, establishment of the Part D plan, the Medicare Prescription Drug and Modernization and Improvement Act really did undermine Medicare to a phenomenal degree. And yeah, that's what you have to do. I mean, if you haven't any resources at all, I would put them towards rehabilitating Medicare for seniors and showing them how to get on traditional Medicare and how to function with that. That is where your aim needs to be, because you're not going to get anything through the Senate over the next couple of years. All right. You may as well be banging your head against a brick wall. The Senate will stop you. But if you get enough seniors to understand what traditional Medicare offers and to fall in love with it, that's tens of millions of people who vote, who could support your cause and tell everyone what they've really got rather than what they think they've got now. That's where you aim your resources if you want to accomplish anything. That is my message.
We're right at 7 p.m. So one last question. Marcia.
Oh, hi, thank you. I just want to mention the National Improved Medicare for All. The act that they're putting forth is actually an improvement on Medicare, I believe. And do you have any thoughts on how that would improve Medicare by that act?
Well, you know, you're kind of trying to accomplish 2 things. You're trying to say, okay, we'll fix Medicare and then everyone can have it. And then all they have to do is block the fixes on Medicare. And I'm saying, why don't you take the Medicare you have and educate seniors what they've got? Because you're kind of trying to do 2 things. And at the same time, you're kind of sending this message. And this is the problem. You're sending the message to everyone, well, it's not good enough, but hey, we can make it better and then offer it to you all. That's not how you sell something, right? Let's make seniors aware of what they actually have. Because every time you say, well, let's try to fix Medicare and then give it to everyone everyone's like, "Ooh, well, what's wrong with it? Why? Huh?" You know, and it's just bad salesmanship when you already have a plan that offers so much more than anyone thinks it does. Start with what you
Interesting.
got.
Thank you.
Thank you so much, David. So really appreciate your presentation and your time answering all of our questions. It's been great, and hope that folks will join us, but also spread the word about the June 30th office hours at 5:30 Pacific time. There will be a presentation specifically going into how does it work at a very basic level, not going deeply into policy. It's really meant for people who just don't really get, don't really get how it works and don't know whether they're ready to support it without knowing more about it. Some people who just think it's got to be better than what we have now, but some people really need more information. So if you have people who are in that category, maybe people who would have benefited from Ed Weisbar's presentation from a conservative crowd, it would be great to welcome them to come to that at 5:30, but we'll have breakout rooms too, because there are many people who don't need that conversation. And people who were there today, obviously hearing Ed give it and then break it down, none of us need that. So the breakout rooms will be for the others who are at a more advanced stage of readiness to go and work for it. And there's also a League of Women Voters Caucus on June 24th at 8 p.m. If you want information on how to do that, you could put your email address in the chat bar here so we can send you an email with the Zoom information, the registration information for that. Thank you so much, folks. Have a good night.
Okay. I guess that's it, huh?
That's it. Thank you.
Sure.
Thank you,
All right.
David.
Well, if you need me for anything else, contact me, I guess.
Thank you. It's been
Thank you,
great.
David.
Really appreciate it.
Thank you. Thank you.